Hello, good morning, bom dia. So just letting you know that we are recording this meeting. It's a very nice pleasure to have all of you here. So we will try to speak only in English all the time, but whenever be comfortable, if somebody just wanna ask in Portuguese, we can help you for translation, okay? I would just ask you, if you don't mind, to come more close to here, because you have this large auditorium. So just to be more close, and let's start it with a more close relationship among just this most important, just have you here, is just try to get connected. And for the strong networking, we should just keep in touch and talk and stay together. Thank you. I would like to ask Professor Leopoldo, the Dean of our school, just to come in for this opening ceremony. And thank you, Leopoldo, to support our meeting here. And Professor Marcos, please. Professor Marcos, you introduce yourself. He's the president of DOHaD Brazil, the Association of DOHaD Brazil. It's a nice pleasure to be here. You can just stay and sit down, please. Yeah. Okay, I'm just starting. So first, I would like just to make a brief comment about what we are just planning this meeting, our expectation. So our purpose here is to bring together experiences from cohort studies carried out in different settings, as you will see over the next 2 days, today and tomorrow, and highlighting key advances and challenges in this research area. As Lifecycle cohort studies continue to expand across the globe, this is an opportunity to understand the dynamic interplay of biological, social, and economic, as well, and environmental factors over time. We hope that this meeting could be an opportunity for sharing insights, methodologies, and innovation that can enhance the impact and relevance of cohort research or cohort studies across diverse populations. This is a huge difference for us from Brazil, from other countries, and just bring together researchers from high and low, middle and low income countries. By facilitating cross-cohort comparisons, harmonization efforts, and knowledge exchange, we aim to improve the global resources for longitudinal studies with high quality data. This is one of the main purpose here, to share, to improve our data collections also, and contribute with scientific evidence for more equitable societies across the life course. This is quite important for us from Brazil and for other countries. So I would like, just before, to ask to our Dean to say some words of welcoming you here, just to mention this amazing team we got together, just thinking about for this meeting, the scientific committee, and especially the organizing the local committee. These amazing people just help us to take care of everything in this meeting. Thank you very much. And I would like to have here Professor Leopoldo, please. Yeah, you can use either one.
Bom dia, good morning. As the Dean of the School of Public Health, sometimes I'm called to lend my voice to the School of Public Health and say some words for meetings like this. And this occasion is especially relevant to me. I am especially glad to give this initial address welcoming you to the School of Public Health, to have this meeting, so special meeting you are producing. I would like to say how we are proud. The school is proud to have the meeting and to have especially the MENA cohort conducted by Professor Marli and colleagues. I remember my students from the School of Dentistry who were so glad to participate in the MENA cohort. They were so nicely received in Acre, in Cruzeiro do Sul, Acre. And I think that I would like to say to you the same as the cross-sectional study said to the cohort study, you are the top. And I really think that your event, your meeting is the top. We are very, very proud to have you at the School of Public Health. Thank you for coming.
Thank you. Thank you. I just ask Professor Marcos, please.
Okay, so good morning, everyone. I just want to say thank you to Professor Marli Cardoso and her amazing team for having organizing this pre-Congress conference for us. I'm here in the dual role as one of the co-chairs for this next starting 3 days, 13th DOHaD World Congress. And also as the president of the DOHaD Brazil Association, which is part of the Latin American DOHaD Regional Society. It's very important for us to have you here today to discuss these amazing cohorts from all over the world. Not just to discuss these cohorts, but also to discuss which are the pitfalls, which are the advices, which we can discuss what's important if you need to start a new cohort study, how to afford this, how to look for collaboration. This is a very important part. I have, although I'm not from the epidemiology and public health field, as a basic science research, I need to recognize the very importance that cohort studies and epidemiology has for DOHaD concept and for the DOHaD studies since its very beginning. So this pre-Congress satellite symposium is also a very important moment for us to start thinking if meetings like this should be part of every DOHaD World Congress. I guess it's a very important part to say now, because in many times we have more or less epidemiology in the scientific program for the Congress, but it's important to have them always present in our scientific program. So again, is a co-chair for the DOHaD World Congress and the president of the DOHaD Brazil Association. I just want to welcome all of you to this amazing two-day symposium. Please enjoy the companion of our colleagues. And again, as Maril said, for the students and trainees here, if you don't feel confident in asking in English, please ask for our help, ask in Portuguese. We can help you out translating, but it's very important that you participate in full of this moment. Thank you so much again for all of you being here, in special our friend Marli Cardoso and all our guests here. Thank you so much.
Thank you, Marcos. Just before I invite another professor to come here, I have just a few words. I just would thank you, Professor Leopoldo, for just last month we have a new room in our school to support breastfeeding and baby care. And we have the youngest participant of our symposium here in this topic. Thank you for just support us in our school to offer this room to help our participants to bring their babies. Yeah. Thank you. And I'm just asking for Fabiola. Professor Fabiola is a pediatrician from Federal University of São Paulo. And I'm just asking you to introduce yourself first. And thank you to support us. She's also in the scientific committee of this meeting.
Good morning. I am very honored to stay here with a lot of very important person and friends, and the youngest person here, Katarina, and she's a daughter of my students. Thank you, Marli, to support us, not just about the meeting, but about the possibility to participation to everybody. So I am Fabiola, I am pediatrician, and I am professor of pediatric nutrition. And now I am a part of DOHaD Brazil, a part of Latin American DOHaD. And now I have a great step here to introduce our next professor here to talk with us in the opening lecture. The title of this lecture is A Maternal Child Cohort Using Electronic Health Records. For this, we will have Professor Lucila Poston. Lucila Poston is the president of International Society by DOHaD, professor of maternal and fetal health, School of Life Course of Population Science, King's College in London, UK. And I am search about the Lucila Poston curriculum, and I saw here she was in 2024, was listed by the research.com as being one of the top 100 female scientists in the world, according to 8 Index. So thank you so much, Professor Lucila Poston, to share with us your presentation. It's our honor to receive you and with your very, very important about health of a woman and babies. Thank you.
Well, hello, everybody. And can I just say I'm absolutely delighted to be here in São Paulo because build up to our Congress in Buenos Aires has taken at least 2 years. It's been a long gestation and we're about to deliver. So that's absolutely wonderful. And to have this meeting in São Paulo as a satellite to the main meeting is wonderful. I think actually I initiated this some time ago. I said to Marcus when we were planning the program, I think it would be really good to have a cohort satellite. And so then it took off. And Marley, thank you very much for taking on the responsibility of bringing it all together. I am also a cohort person, so that's why I'm talking now. So I'm going to talk some science, but just a little bit about the International DOHaD Society. I hope you're all members of the Latin American Society and of DOHaD Brazil. If you're not, please join up. There's a Latin American DOHaD is probably our most active regional society. It's absolutely fantastic. It really is. It's really buzzing. Especially for young graduates and postdocs. It's a wonderful community. So you're missing out if you're not a member of it. So please do join. But just the rest of we now have 10 regional societies in the DOHaD International Society. And we're going to announce our latest at the meeting next week, which is going to be in India. Surprisingly enough, a lot of DOHaD work has been done, a lot of cohorts, as you know, in India, but they have never joined as a DOHaD India. And we've got some really good, excellent people who are going to lead that. And so we'll be launching that at the meeting next week. And we've also launched a European DOHaD. I mean, DOHaD actually started in the United Kingdom. And so we didn't really bother having a European DOHaD because we were sort of working all there together. But now we've formalized that, and it's being led by Melanie Conrad from Germany. And we're having the first workshop there next year where I think there'll be quite an emphasis on mental health and cohorts and so on. So if you're interested in coming along, it's not actually just confined to people in Europe. So the society is growing, and it's slightly more formalized now in terms of our structure. We have these 10 regional societies who all report back to the International Society. And we also, as the International Society, fund our regional societies, particularly in low middle income countries, so that we can enable them to come to meetings, come to our workshops and so on. So have a look on the website, which has all been revamped in the last year or so, and familiarize yourself with the society if you're not terribly aware of it. So that's enough about DOHaD, but I'd just like to, again, thank Marley and Marcus, yourself. It's lovely to see Marcus. We've been seeing each other on Zoom for 2 years, and it's absolutely wonderful to see you in person. And this guy has done so much hard work on behalf of the society. Thank you very much, Marcus. It's wonderful. So what am I going to talk about today? Well, when I looked at the program, I thought perhaps I'm talking about the wrong cohort, but I hope you'll find this interesting, what I have to say. But just to say what I have done most recently is to do a cohort of women living with obesity in pregnancy. And we've been following up their children. And that was a cohort of 1,500 ladies in the United Kingdom, the Upbeat cohort. And you may know that there are many, many papers. We had just to give an idea about design of studies, we designed that studies to give us a rich bioresource, very granular data, follow-up of the children planned. I mean, the children are now 12 and 14. We're just finishing off the last cohort. But that's been such a wonderful resource for us, as all of you doing some wonderful cohorts across the world. But, you know, the design of these cohorts right at the beginning, it was actually an intervention study in obese pregnant ladies to see if we could prevent gestational diabetes. I designed it as a life cycle cohort, unbeknownst to the funders. So we had collected all the right data to do that. So what I'm going to talk about today is what has really captivated me in the last few years, and there's been a lot of hard work in the United Kingdom. I work in King's College London, and we've been encouraged in England to start using our National Health Service data for research far more than we have done in the past. So the government is trying to support us to do that. And it's been a voyage of discovery for me because I've never worked with routine electronic health records before. But I thought I'd give you an insight into it. I know in Brazil, there's a fantastic electronic health record linkages here, which actually have really been internationally recognized. In the United Kingdom, we're a little bit behind in that regard. But to my point of view, I think going forward, these cohorts offer an enormous amount of opportunity. You can also do intervention studies, trial emulation studies, interrupted time series, and so on. So I'm just going to tell you a bit about what we did. And we started doing this in 2015, believe it or not. It took us 3 years to get the necessary permissions to start it. But now we're actually getting some data out of it. So I'm going to talk you through it and show you what we've done and where we're going in terms of the data. So I work in London in the United Kingdom, and our hospitals, the two major hospitals in that part of London are Guy's and St Thomas's Trust and King's College Hospital Trust. Our hospitals are called trusts. But we serve a certain area of South London, which is a highly deprived population, which is quite remarkable. We look north over the River Thames, we see the Houses of Parliament. And if we look south, we see an area of some of the greatest deprivation in the United Kingdom. Inner city, multi-ethnic population. We have about 20% Black women in our population, our pregnant population, and 50% of our women who attend our antenatal care were not born in the United Kingdom. So this is a very high risk, migrant-heavy population. So we decided to do the linkage there because this was an at-risk population from which we could learn a lot about inequalities in women's health. And we also are fortunate to be able to work with a mental health trust, which is called South London and Maudsley. So what we have done, which is relatively unique, is bring together both physical and mental health data in pregnancy and in the children as well. And that is proving a great strength of what we're doing. So at the moment, we've been doing this now since 2018. We have 73,000 women in the cohort, and we download from the cohort twice a year, so it's increasing yearly. So this gives a sort of schematic representation of what we've done and what we're planning to do. So in the center there is the core of our data. Now, the reason we can do these linkages in the United Kingdom is because every person who is born in the United Kingdom has a unique identifier, which is the NHS number. And when a mother gives birth to their baby, the mother's NHS number is always linked in the antenatal record to the baby's NHS number. So we can always link together mothers and babies. And we also do not have that much private healthcare in the United Kingdom compared to the NHS. The vast majority of people have their babies in NHS hospitals, and the children and the mothers go on and are treated by the NHS throughout their lives. So we do have a pretty unique opportunity to manage to link all the data. Unfortunately, as in most countries, the data for antenatal care is on a different data set from the data from primary care, different database from the Mental Health Trust. So we have to link them together, and to do that is obviously not that easy a task. So what we've done so far, shown in the middle here, we've linked antenatal maternity data. The database we use, and a lot of hospitals in the UK do use, is called BadgerNet. We're now moving to EPIC, actually, which you'll be more familiar with. The NICU, the neonatal intensive care data is on a separate data set, but also run by BadgerNet. Then recently we've added in health visitor data. Now this in the United Kingdom, I'll tell you a little bit about this, is new. Most people have not used health visitor data in linkages so far, and there are reasons for that. But it actually gives us data from the babies from the day they are born all the way up to 2.5 years. And then they go to school at the age of 4. So we start getting data from national records of schools. The mental health data is on a platform called CRIS, and we get the primary care records from our local general practitioners. So that is now all linked, and that's linked centrally. And then we add to that linkages from national data sets. So HES is the hospital episode statistics, which tells us when a woman has been in a hospital or a child, and whether they've been to a clinic or not. But that is not very granular data. The data we get from the absolute antenatal care data is incredibly detailed. The national data sets are not nearly as detailed as we would like for some of our research, but they're nonetheless useful. So we're about to link, as the children grow older, the linkage of the child with the National Child Measurement Programme. All of our children are measured for weight and height from when they go to school onwards at intervals. And then we have the National Pupil Database, which tells us in great detail about their educational attainment. So you can imagine this is really useful for follow-up life cycle studies, that we are able now to get ages and stages questionnaires from the health visitor data, and then follow on. We get the mental health data and the educational data as the children grow up. Then, as needs be, we add in data from some of our pediatric clinics. The Evelina Hospital is our child hospital. We've been having very interesting time trying to find vaccination data in the last few weeks. I could really bore you with that. It is not easy to find in the United Kingdom, but we're getting there. But we want to look at immunization itself. And then we have plans to, this is the fertilization, Human Fertilization Embryo Authority, which is about IVF. We have data from pollution, which is really good in London. And we had a student who's now adding that on to a PhD studentship. And these are social care data. CAFCAS is the child court data, which we are planning to get. And actually, we're doing that with our Institute of Psychiatry, who have it already. So this is the major plan, and it's already taken us, it's taken us since 2018 to get as far as we've got. But it's proving to be really useful and incredibly interesting. So just, should you ever be thinking of this, and I don't know what the situation is in São Paulo and other parts of Brazil, but we have to get through all the regulatory hoops, as I expect you do here, which takes a long time, and it's incredibly boring filling in all the forms. So we have to get ethics approval. All of our women come in on the basis of opt-out consent, which means we get all of the data, but not those people who want to opt out. So we have to get a form called a Section 251, but we do have to make sure that everybody in our community knows about the study. So we have to advertise it. When people book for antenatal care, they see it in the notes, and if they want to opt out, they can opt out. They can also opt out of all research with their GPs, and the GPs ask everybody whether they want to put their data in for research or not. Then we have to go through all the hoops of data management, storage and curation, which have to be very well regulated. Data sharing and access is incredibly important. The Medical Research Council, who funds our work, insists that we make it available. So we have something called HDR UK, which is our Research UK data register, where the data can be applied for. And then people apply to us to use the data. We have an oversight committee, and we have a form, and then we look at it. We have lay members. We decide whether it overlaps with other projects. We decide whether it's academically good. And then we enable the research team to access the data, and they have to have special permissions to do that. So the form filling that goes on and on and on. And then we have to comply with what the institution makes us do for data protection. This is nothing new, but it does take a long time. And then to get the data, getting the national databases is notoriously slow. But we are working our way around that, and it's actually getting quicker now that the government is helping us more. Then all of the things that you have to do with any very large data set, we have to do data cleaning, we have to develop the scripts that the individual projects want to use, which we do have some routine data cleaning that goes on every download. We have to think about rules for imputation and data missingness and so on. But one thing which is very good is that we are feeding back to the clinical staff and the clinical IT people about how good the data is for our purpose, for research, but also for their purpose, because you'll find that blood pressure comes in 5 times when it only needs to be in 3 and all that sort of thing. So we feed back and we find data by looking at primary care records, looking at secondary care records, and so on. So we think, you know, triangulation is the name of the game when we're trying to look for data which might not be obvious in one database, it might be there in others. So a lot of work, but it's all been very interesting and worthwhile. So the obvious opportunities of having a birth cohort linkage like this are that it is actually, you can use the data almost in real time. So you can immediately respond to a particular intervention, or for example, like COVID, we've done a lot of work with the COVID cohort and following up the children almost in real time, and that is hugely important. We're also working with government who have asked us to look at 1 or 2 interventions, and we can do it almost responding. We did one study I'll show you within 3 months of getting the request to do it. We're very keen on using artificial intelligence for natural language processing, and we're beginning to do that. We work with a group who have developed a natural language processing database called CogStack, which is very good. So we're doing that. And then you can follow interventions at the population level, as I mentioned, either by interrupted time series or by just regression analysis. And then you can think of doing trials with data, real-world trials, where you would perhaps have a group of people who have been on a drug and those who have not, and then you do propensity score matching to match up a control population, and so on. And evidence from these real-world trials is now good enough to inform practice in certain parts of the world, including the UK. It's still in its early days yet, and we feed back to the healthcare providers to improve the data. So now I'm just going to take you through a few of the studies that we've done and the sort of thing that we're doing and what we're planning to do in the future. So this is the study I mentioned that we did within 3 months of getting the funding from the National Institute of Health Research in the UK. And this was that the government was very keen on reducing the burden of healthcare in the winter months from respiratory conditions, particularly asthma, childhood asthma, and adult asthma. And they had 3 interventions that they hoped might work. One was just giving blanket advice, which was actually very impressive, you know, to GPs and patients. Support payments, winter support payments to people to try and improve their conditions at home, to help heating and so on. And then vaccination for children, like respiratory syncytial virus and so on. But they wanted to know which of those interventions was better. So they asked one of the guys in our population health department, who was actually an AI expert, and he applied. Now, if you want to see this paper, it is full of equations, which I cannot go into, but he did some really good simulation in 150,000 individuals, amongst whom are 32,000 women from our birth cohort. So we got a lot of the young children and the mothers. And just to cut a long story short, what he found was, and that the data is not shown there, that people in low socioeconomic status and those with middle socioeconomic status did require more access to healthcare for respiratory conditions during the winter months, but those in higher income status didn't. So on the right here is shown the relative effects of the advice intervention, the support payments, and the vaccinations in the lowest socioeconomic group. And in fact, the advice was the best intervention because it reduced the number of healthcare visits for asthma within the primary care data sets. And that also applied to the middle group, but not to the high income group. So we were able to say, according to this simulation, this modeling, that the best advice was actually the best intervention was the advice that was given to the government to the population to prevent respiratory disease in the winter. So that's just an example. That was very rapidly done by one of our AI experts who's now working with us. And AI, of course, in terms of prediction, assessment, and so on, in these huge data sets is going to be incredibly valuable with time. So I mentioned that we've been looking at the COVID pandemic, and this is an interesting study which has just been accepted for the American Journal of Obstetrics and Gynecology. And this was actually looking at the impact of, during the COVID pandemic, of virtual clinic visits, so through Teams or through Zoom. So in the United Kingdom, we did a lot of this. A lot of people did not come into the hospital. They preferred not to come into the hospital for clinic appointments, and they received their care virtually. So there's been a big question as to whether this was disadvantageous or whether it was a good thing and very good for reducing healthcare costs. And indeed, in the United Kingdom, this has stuck in some ways that we have quite a few antenatal visits which are still virtual. So Katie Dalrymple, who was my PhD student, is now a lecturer. She did some very smart modeling, group-based trajectory modeling. And actually what she did was to identify women who had practically no virtual appointments, those who had a middle number of virtual appointments, and those who had the most virtual appointments, and looked in those groups at the trajectories in relation to adverse outcomes in pregnancy. So what she found was that virtual antenatal care was associated with less gestational hypertension. That might seem to be a good thing. That was because they weren't having their blood pressure measured. So in fact, they probably had more hypertension, but there was less measurement of it. But more preterm birth, more labor induction, more assisted vaginal delivery, more breech presentations, more C-section, more postpartum hemorrhage, a lower breastfeeding rate in these children, and higher NICU, that's neonatal intensive care admission. So, of course, we're really interested in this cohort because they are now growing up and we can now follow them up, because the question is whether these virtual antenatal appointments had a lasting effect on child health. And we will probably find that there's more premature birth and so on, lower breastfeeding rates. So that is the beginning of a life cycle type cohort. But this was in, I think, about 45,000 of the cohort. And then the other thing, which also we've just published in BMC Medicine, we did a very detailed health economic evaluation of the virtual visits, and found actually, because of the increase in adverse outcomes, which are expensive for the health service, that they were more costly than the face-to-face appointments. So a lesson to be learnt, but just gives some idea of how we can use these cohorts to answer important questions in health service delivery, but also, of course, in relation to the health of the mother and the child. So I mentioned the health visitor data. Now, in the UK, this is I'm personally waging war on the government about this, because we have health visitors, a wonderful team of people, and this is much the same in Australia, New Zealand, lots of other countries, probably Brazil, but I don't know. Health visitors who visit the mother at home when the baby's born in the first week after delivery, and then they do a breastfeeding review at 6 to 8 weeks. Then they do a health review at 12 to 15 months and a health review at 24 to 30 months. They collect a wonderful, rich data set, but all the government is interested in at the moment is knowing whether the health visitor has seen the patient, that contact has been made. So they only report to government the number of visits which have occurred, and all of this data sits in all the individual local authorities and is never used. And so we have just done the first study which actually uses, believe it or not, the English health visitor data. There's been a study in Scotland, which tells us about neurodevelopmental milestones. It's ages and stages questionnaires at Health Review 2, and it's a very valuable resource for early child neurodevelopment. It also has very good data on growth trajectories and weight and so on. And that has at the moment never been used, and we're actually doing a study to bring that in. So there is apparently more resource going into this service now. We've been talking to the Department of Health in the United Kingdom about it, but it is so important. In life cycle, if you're going to do anything with life cycle using routine data, you need to fill in that gap between delivery and school. And this is how we wish to do it. We have a service which is underutilized at the moment. So just to give you some data which is sort of hot off the press, my postdoc, Sumon Lat, who's been looking at the data. So I would just pay attention to the right-hand side here. This is about the effect of lockdown itself, not infection, but lockdown that we had and you had and across the world. 3 lockdowns in the United Kingdom. And we looked at the neurodevelopmental outcomes according to how many lockdowns each child had been exposed to. So what this is telling us is that those children exposed to 3 lockdown periods had lower problem-solving skills. That was the most significant one, and a hint at poorer communication skills. Well, that's not surprising, given they were not going to nursery school, they were not meeting their other children. And this corroborates some other small studies, and there've been few and they've been contradictory, which suggests that the lockdowns had a cumulative effect on the neurodevelopment of the children. But there again, we will be following up these children when they get to school with a national pupil database to see whether there was an impact. So there are lots of people looking at this, but this is just the first study that we've done using the health visitor data. And as I said, it's the first time it's ever been done in England using outcomes of these visits, which is absolutely appalling. Talking about inequalities, we have a senior lecturer called Hannah Raymond-Jones, who's been looking at inequalities, which, as I mentioned, in our population are rife in terms of economic income, in terms of ethnic minorities, and so on. So what she's been doing is to assess, using WHO framework for the social determinants of health, which is on the right here, to assess how structural determinants of health. So these are things you can't do anything about, like ethnicity, so where you live, education, and so on. So combining and looking at socioeconomic variables, structural determinants, and things you can do something about, which is access to healthcare, maternal diet, and so on. So Hannah has used this framework using our birth cohort, which typically we would only look at educational attainment, ethnicity, income, but she's now added to that by looking at all of these other variables. In 67,000 pregnancies, a paper which has just been submitted, and looking at the composite outcome of emergency cesarean section, hemorrhage, preterm birth, low birth weight, and so on, to see what the determinants of adverse outcomes are in this population, looking at these complex factors which are involved. So, unsurprisingly, in terms of the structural factors, the immovable ones, ethnicity, migration, deprivation, most deprived areas, were all significantly associated with adverse pregnancy outcomes using this the outcome variables. But intermediary factors not done before: social support, unemployment, particular financial housing, hardship, social housing, missed appointments, antenatal care, unscheduled care, and transfer of care between providers were all adding to the risk. And so adding this all together, they were cumulative, these risks, and that's never been done before in a UK population, looking at all these variables which might relate to adverse pregnancy outcomes. And of course, the intermediary factors are modifiable, and those are the ones we need to think about in terms of developing interventions. And of course, she is now looking at the children as they're growing up. So I'd just like to end by telling you, we're not doing this in isolation in the United Kingdom, because several other groups are also doing mother-child cohorts using electronic health records. And we formed a partnership called MIRADA, which is Mother and Infant Research Electronic Data Analysis. And it's run by the University of Swansea and Cardiff, the 2 Welsh universities. So we have born in Scotland, born in Wales, born in South London, born in Bradford, but the born in Bradford is doing an electronic health record study now. And we're putting them all together to do a federated analysis. Well, that isn't as easy as you might think, because everybody collects data, as I said, on different platforms. So how do we harmonize data from different cohorts? And this is an international problem. If we want to work internationally with our birth cohorts, how do we harmonize our health records so that we can aggregate them and do federated analysis or meta-analysis? So what we've been doing, and those of you in the data science world will know about this, is using a common data model called OMOP, which essentially what you have to do in this is to recode all of your data in a harmonized way so that you can all look at each other's data and understand what it means. So the Observational Medical Outcomes Partnership Common Data Model is an open community data standard designed to standardize the structure and content of observational data and to enable efficient analyses. So these slides were given to me by our OMOP friends, and this is unbelievably complicated in doing. I mean, we've just finished this, and it is an incredibly complex exercise to do. But this is just to show how many different ways in terms of terminology data is reported. All these ICD-10 codes you'll probably be familiar with, the International Data Code for Diagnoses. But then in the UK, our primary care people use SNOMED codes. There is a whole bunch of them across the world that people use to define what the disease outcomes are. Then in terms of the content and of the care given, there are all these different data, the different standards of collecting the data, and so on. So everything is done differently across the world with different coding, and it's a complete nightmare. Those of you who are involved with this will know what I'm talking about. So these very brave people who developed OMOP got going between 2009, 2010, and actually now 80 countries are mapping their data using these standards. So essentially a whole new coding system has been developed, and it's added to the whole time. We were the first to do the antenatal data in any detail. Oxford University and Norway have done some of it, but I think we've got a very granular data set for antenatal care, but it takes a long time. And the codes aren't there, you have to invent them. So it is expanding the whole time. But it is working, and people are beginning to work with one another using those codes. So this is just a rather nice way of describing, you know, in relation to the plug sockets. Actually, in my hotel room, I've got 3 different plug sockets. So it came back to me, and I came with a great bag of adapters. But here you have all these different coded coding. The UK Biobanks developed its own codes. And in old-fashioned speak, you would have to have an adapter like I have for all these different sockets. But essentially what OMOP is doing is creating one universal adapter for the whole thing. And I think that's a very nice way of describing it. So anyhow, this is another way just showing that all the different variables that you have in the different sections of healthcare data have all been mapped against now a standardized code. So we've done that. So just to finish off, so what are we doing now? So we have, with Mirada, we have aggregated data for antenatal care. We're going to add on health visitor data, so on, and expand it. And we're working together because we want to know what's happening regionally in the United Kingdom. So to give you an example, and again, we're a bit behind here, the United Kingdom is only just introducing supplementation of folic acid in flour this year. Shock horror, because you've done it very well in South America. But we haven't, because we've had some evangelists who said it's dangerous. I won't go into the background of that. So I also sit on the Government Advisory Committee for Nutrition, and we've been fighting for this for years against these people who said, no, everybody's going to get colon cancer. They're all going to get pernicious anemia. You know, unbelievable. Anyhow, it's happening. So we have put in an application to the Medical Research Council to evaluate this now using these 4 cohorts. And several of the cohorts, including ours, also have a bioresource collection, which is by consent. So we'll be looking at the status of folic acid status across the devolved nations, as we call them. And we'll be looking at the child outcomes. And really importantly, and I think this is often forgotten about folic acid, is that it's not only NTDs which might benefit, but fetal growth is likely to improve. I mean, not lots of observational studies, very nice cohort studies, which have shown that folic acid supplementation seems to increase fetal growth. Then anemia is associated with folic acid insufficiency, and neurodevelopmental outcomes in children. Big cohort studies suggested that. So with our aggregate cohort data, we were planning to bring all of this together in a big time-interrupted series. And we'll be looking at long-term follow-up of children and developing interventions according to, as I was saying, the structure and intermediary determinants of adverse outcomes in the mother. We will then be following the children. We've got a big study going at the moment looking at the immigrants in our population who do very badly in terms of pregnancy outcome. And we will also be following up those children in a life cycle way. And then I mentioned the fact that we have mental health data, which is proving invaluable. We are seeing a lot of interaction between physical and mental health and childhood outcomes and maternal outcomes. We've got a study funded by the Wellcome Trust to look at adolescent pregnancies and looking at the interaction between mental health and physical health outcomes there. and a new study too, on women with learning difficulties and their access to care and whether they can benefit from, well, we can benefit by getting intervention to help them. So that's not as much as I'm going to say. Of course, I lead the team, but as a person who leads the team, I depend on fantastic people in the team, and we have a psychiatrist, we have a professor of women's health, a medical physician, we have a wonderful study coordinator, we have the people who do the linkages in the Institute of Psychiatry, and I just sit and chair the meetings and let them get on with all the work, which is enormous. And to thank our funders, predominantly the Medical Research Council. Thank you very much.
We are talking now that you will have a coffee break, but it's a coffee break to think about the presentation of Professor Poston. And after the presentation of Professor Matthew, we'll have questions and answers and discuss the two topics together. The questions could be in English or in Portuguese. We can help everybody with the translation. Don't worry, okay? Thank you so much. Thank you so much, Professor
Thank you very
Lucila.
much. Thank you for the
I would just like ask Professor Marcus just coming here.
Well, good morning again. It's my pleasure to introduce our next speaker, Professor Matthew Gilman. Professor Matthew joined the National Institutes of Health in 2016 as an inaugural director of the Environment Influences on Child Health Outcomes ECO program office in the Office of Director. He joined NIH from Harvard Med School, where he was a professor of population medicine. He was also professor of nutrition at Harvard School of Public Health. Dr. Gilman has a background in the fields of epidemiology, pediatrics, and internal medicine. He came to NIH with experience in leading or collaborating on cohort studies and clinical trials. Dr. Gilman received a bachelor degree from Harvard College, earned a medical degree from Duke University, completed a Med and PEDS residency at North Carolina Memorial Hospital, and received a master's degree in epidemiology from Harvard School of Public Health. Among other awards, Dr. Gilman was the 2017 recipient of the David Barker Medal from the International Society for Developmental Awareness of Health and Disease. Since coming to NIH, Dr. Gilman has overseen the development of and now impact from the ECO program, which focuses on 5 key pediatric outcomes with large public health impact: pre, peri, and postnatal, upper and lower airway, obesity, neurodevelopment, and positive health or well-being. The program has 2 major components: the ECO cohort for observational research and the ECO Idea States Pediatric Clinics Trials Network, ISPCTN, for intervention research. My dear friend Matthew, it's a pleasure to have you here with us. Please, the microphone is yours.
Thank you so much, Marcus. It's really a pleasure to be here in São Paulo. It's my first time here. I've already witnessed and been the beneficiary of so much hospitality. I really appreciate the scientific committee and the local organizing committee for the invitation to be here and to see so many people in the audience, not only professors, doctors, but also all the students here. Do you want me to repeat what I just said? So I'm going to talk to you today about challenges in mounting, that means inspiring, building, leading the ECHO cohort. This is not going to be a presentation about the results. I will present some results on Sunday in Buenos Aires if you're able to be there, but more about the nuts and bolts of building the cohort, somewhat along the same lines that you hear Professor Poston talk about just a moment ago. So today, I'm going to start by telling you something about the ECHO program and a focus on the cohort part of the ECHO program. and then talk about selected challenges that we have faced. So we faced a lot of challenges. Some of them have solutions. Some of them beget new challenges, and then I'll finish with key takeaways. So ECHO stands for Environmental Influences on Child Health Outcomes. And this is a program supported by the U.S. National Institutes of Health, or NIH. So our mission in ECHO, which we try to keep our mind on all the time, when we get into sticky situations, we say, we're here for the kids. So our mission is to enhance the health of children for generations to come. And as Marcus mentioned, we focus on 5 key areas with high public health burden. So one is pre, peri, and postnatal outcomes. So preterm birth, maternal depression. Upper and lower airway in the kids, so that might be asthma and allergies. Obesity and its consequences. Neurodevelopment, examples are autism spectrum disorder, attention deficit disorder, and cognition. And a 5th outcome we call positive health. So that's not about the absence of disease, it's actually about the positive valences of well-being. We do our work in observational and intervention research. On the observational side, we have the ECHO cohort. So this is the largest longitudinal study of kids in the United States. And we're following about 60,000 children now from preconception through 21 years. We also have the ECHO Idea States Pediatric Clinical Trials Network, affectionately called ISPCTN. This is a state-of-the-art clinical trials network for rural or underserved kids, and it's in 18 US states with low NIH funding. So there's a lot of building capacity to do clinical trials in this network. Altogether, we fund institutions in 42 of the 50 United States and District of Columbia and Puerto Rico. So let's talk about the ECHO cohort. So our overall goal in the ECHO cohort is to answer solution-oriented questions about the effects of a broad range of early environmental exposures on child health and development. And I'll tell you more about this goal as we go on. We started in September 2016. And in our first 7 years, what we did was take data from 70 pre-existing, ongoing maternal child health longitudinal studies and harmonize their data. Lucilla has already talked to you about some of the challenges of harmonizing data. So you can imagine when we take these pre-existing studies and try to put them together, there are a lot of challenges. And you can imagine some other challenges too. And I'll talk to you about those in a moment. Where we are today, though, starting just about 2 years ago, is following up 30,000 of the kids that we had in this first cycle. We're recruiting about 30,000 new pregnancies. We have a preconception component, and we have this rapidly expanding data platform and biorepository with data now from about 150,000 children and their family members. And I'll talk to you about how you can access the data as well. Recruitment, retention, data, and specimen collection are going well here in this second phase. So here are 6 selected challenges. I'll lay them out in this table, and then I'll go through them one at a time. So I mentioned these many existing cohort studies coming in. Data harmonization is a big issue. We had to create ontologies and new methods. You've heard some ideas about how to do that with electronic records. And now we have one ECHO cohort. Well, how did we fund the investigators across the country in this cohort? Through something called cooperative agreements, which I'll tell you about. But that meant that we had hundreds of principal investigators all over the United States. How did we engage them to do common work, to do collaborative work? And I'll talk to you about some of those ideas. We have multiple components. We have the cohort sites, we have our cores, we have our centers. We want to integrate them into the whole. So I'll talk to you about the science of team science. From the very beginning, we wanted to include a preconception phase in our study. And And we recognized early on that that would be very expensive to get a modest number of women in the preconception phase and an even more modest number of births. So in the beginning, we found it too complex, and we spent years designing a way to do preconception work. And I'll tell you how we're doing that now by recruiting interpregnancy. And then, of course, we want impact. We want the impact of this consortium, the whole of the consortium, to be greater than the sum of the parts. So each of these investigators could do their own work, but what do we get by putting them all together? So we started talking about solution-oriented research, which in the beginning was a very unfamiliar concept, but now people are talking about it. It's really in the vernacular. And another way to expand the reach of ECHO research is to make data available not only to our investigators, but to the broad scientific community. And we've started doing that with de-identified data and now with identified data. And as Lucilla had mentioned, one of the key issues is data stewardship. Okay, so how did we go about establishing one ECHO cohort? So as I mentioned, in 2016 to 2023, we had pre-existing studies. They were designed by each of those investigators. They had different inclusion criteria. They had different timing of when the visits were. They had different variables. So we spent 5 to 6 years doing harmonization. Our data analysis center really brought their expertise to this. Some things are easy to harmonize because the variable here is the same as the variable over there. That's a rare occurrence in studies like this. Then there are ways to do this with mathematical modeling by saying we'll take some elements of this, we'll take some elements of that, we'll put it together and see what a common data element might be. And then there are other ways to do it through regression modeling, through missing data techniques. And ultimately, you want to come out with a common data model with variables, derived variables that everybody can use. There are many, many examples of this in ECHO. One, for example, is that there were 8 different tools to measure postpartum depression. And through harmonization, we're able to map those to one scale. We were still left with a semi-standardized data and specimen collection protocol in our child follow-up. All the studies had a pregnancy component, and now we're in the child follow-up. And with all this variability, you know, we had tens of thousands of participants. But when you get down to the variables that are common, you can wind up having analyses that are only among 100 or thousands. So you really are not using the complete power of the cohort when you have all of these harmonization challenges left over. So how have we overcome that in the present? Well, the first thing is we continue to follow up the children, but we're also now, as I mentioned, having a new pregnancy and preconception phase of the cohort. So that allows us to sort of start over with a standardized protocol. So now we have a very standardized protocol, and it's both for the child follow-up and for the new pregnancies. In the past, we had federated ethical approval with the institutional review boards. Now we have a single. We have centralized data capture from our data analysis center. So it's not each cohort site going out, collecting its data and sending it in. It's the data analysis center sending out most of the questionnaires. Thank you. We also changed our governance structure. In the first part of ECHO, I think we had a very inclusive governance structure where we had many people deciding things. Now we have a more efficient data structure with a representative governance. So we're able to make decisions more quickly and more effectively, but still try to have this inclusion. So everything is a balance between efficiency and inclusion. And the other thing is we oversee the quality of the cohort. And so there's this balance between, do we let the principal investigators have more autonomy over the oversight, or do we have more autonomy over the oversight? And in the second cycle, we have a little more autonomy as the funders. Now, what about engaging the investigators in the commons? This isn't such a problem when you have a national cohort run by a small group of people. But when you have hundreds of principal investigators and more than 1,000 researchers, people go off in their own directions. So what's the organization of ECHO? So you'll see here in the middle, the NIH program team. We call ourselves small but mighty. We're a total of 16 people to run this nationwide cohort. There's a cast of thousands across all of these components with 73 cohort sites, our coordinating center, our data analysis center, our measurement core, and our laboratory core. So the way we fund these is through cooperative agreements. So a cooperative agreement is a way of funding in the United States from NIH that covers high priority areas. Usually in a grant, NIH would say, we like your aims, here's the money, go off and do your work and tell us every year what you've done. In a cooperative agreement, the NIH scientists have more inclusion and more involvement in the research. And so what we typically do in the program office is set a vision for the program. So I came in 9 years ago and I said, we're going to be a cohort that exists under the DOHaD paradigm. We're going to be looking at early exposures and then outcomes throughout childhood. Okay, so that setting that vision has a lot of ramifications about how we set up the protocol, how we work together, what kind of science people do, etc. And then we set boundaries. When people are going off into the wilderness, we say, yeah, come back here. Don't you remember what we're here for? But it's the investigators who drive the science. And here you can see some small teams of investigators. However, when I came into this director position, I called all the investigators and I said, you know, I think my job is like herding cats. I don't know if you've heard that expression, but herding cats is a very difficult thing to do. Cats like to go off in their own direction. They're very autonomous, and you can't take a lasso and get them all together. And one of my investigators said, no, your job is like herding lions, because many principal investigators are strong-willed. They want to do what they've always done, and we have to get them together. So these are some notes on the gentle art of herding cats. Now, whether these cats are household cats or lions on the Serengeti, cats don't like to be herded. In fact, you can't really herd cats. Cats prefer to herd themselves. Cats understand that they sometimes need to be herded, and that doesn't make them any easier to herd. The fourth is cats don't like being reminded that they're being herded. And 5, harsh herding has negative consequences. So this is my job. And in fact, some lions still prefer to go their own ways. This is the centrifugal force, but we want a centripetal force where ECHO succeeds when we're all on the same merry-go-round. So that involves some carrots and some sticks. So this is the part where we try to put food in front of the cats. I don't think lions really like carrots, so this is a bit of a mixed metaphor, but let them herd themselves. So how do we do that? Well, our scientific carrots involve, as I said before, focusing on the mission. It's all about the kids. Sometimes when we get into these details about should we do this decision or that decision, or what's the denominator and what's the numerator, we go, wait a second. Let's jump out for a minute and talk about why we're here and what's the overall goal. As I said, the DOHaD hypothesis, the DOHaD paradigm, allows us to focus on this good start to life. We're trying to prevent common childhood disease and promote health. So that's another organizing principle. And then some cross-cutting themes that we've put in include the science of team science, which I'll tell you a little bit more about. The whole is greater than the sum of the parts. The solution-oriented research, which I'll also tell you more about, including engaging our end users. Our end users are the people outside, the policymakers, the people who develop practice guidelines, the people who are doing public health programs. What is the research that they need? And then supporting the next generation of researchers, which we do in many ways throughout ECHO, all adhering to our guiding principles of teamwork, impact, responsibility, and value. Of course, we have a few sticks because we're the funders. So we provide the money to the investigators to do the work. So we align award funding with accomplishment and potential. And then we set long-term goals and annual objectives, indicators, and targets. So these targets are things that the cohort as a whole is trying to achieve. There are gold standards for how a cohort should be and how a collaboration should be. So we have collaboration in the leadership metrics, as well as metrics about what makes a good cohort study, like recruitment, retention, complete and accurate data collection and specimen collection. So what's our shared accountability model using the science of team science? As I mentioned before, we have our small team in the office, but we also have many, many teams throughout the consortium, our committees, our working groups, our task forces. Each of these is a team, and team science involves a number of qualities. One is leadership. That's leadership as a whole, but it's a leadership of the small teams. It's collective vision. So does everyone buy into the DOHaD principle? Does everyone buy into a number of other things that we think are principles for the entire cohort? Building trust is a big thing. That's even among our collaborators and our investigators. They don't know each other when a new component comes in. We have to build that trust over time. Shared credit is extremely important. We know that investigators get promoted in their institutions from individual accomplishment, but they're also now more and more getting promoted for shared accomplishment. And our ability to share the credit and have the investigators share the credit with each other redounds to their success in the future. Emotional intelligence goes along with trust. We need to listen to people. We need to understand where they're coming from and respond. Communication, of course, is key. This is not just communication from us out to our stakeholders. It's bi-directional communication among all of us. And then we focus a lot on team dynamics. What are the things that make a good team work? All right, those are some of our cross-cutting themes. Now let me turn to one of the scientific things that we were most interested in, which is preconceptional origins of child health outcomes. So our outcomes of ECHO occur from birth to 21 years in those 5 outcome areas that I talked about near the beginning. We define our exposure period as conception to age 5, the first 2,000 days, because these are the times during development which are most plastic, and our perturbations or our positive attributes during those times set us on trajectories for lifetime health. When we started, almost all our data began in pregnancy. We had a little bit of preconception data from some of our sites, but what we really wanted to do was have a nationwide preconception phase, because we know that sometimes pregnancy is too late to start, that we need to figure out what are the determinants of child health that occur even before pregnancy starts, both in the mother and in the father. And so how are we going to do that? Well, about 4 years ago, we convened an international panel for a workshop on preconceptional origins of child health outcomes. And this gave us a refined roadmap about how we might do our work in ECHO to incorporate the preconception period. What we recognized as challenges from previous research in preconception is most of it is with intended pregnancies. So intended pregnancies typically involves a couple, not just a woman. They tend to be higher socioeconomic status, and that means they typically have fewer adverse outcomes. So we're really interested in a more general population sample. But then we recognized that it's really too expensive to recruit a general sample before the first pregnancy. That's what a national study before ours tried to do, and it really fell down because it was too complicated. If you try to go house to house to find people who are likely to get pregnant, you'll have to go to 100,000 households to maybe get a couple thousand births. So it's really unwieldy. So our solution is to recruit in the interpregnancy interval, because each echo delivery occurs and the likelihood is pretty high that that woman will have another pregnancy within our 7-year funding cycle. And in fact, most of them will be in the first year or two, or maybe the third year. And because we're already following up the mothers and the children, there are many relevant data and specimens that we're already collecting from the postnatal visit. So this makes preconception recruitment at least plausible and feasible. We recognize that it doesn't involve the primiparous women, but you can't have everything when you do preconception research. Our recruitment started just about a year ago, and we're now just starting to recruit the partners. So these are the prospective fathers, and we're collecting data and specimens from them as well. So I think we'll have some data on the preconception phase next year or the year after. Okay, let me conclude by talking about impact. So I mentioned solution-oriented research. So we define solution-oriented research in ECHO as so what questions that lead to impactful interventions, public health programs, clinical practices, and policies. And this idea comes from a really nice paper written about 20 years ago by Robinson and Serrard, who said, do a research study only if you know what you will conclude from each possible result, and the result may change how you would intervene to address a clinical, policy, or public health problem. So this is another one of these principles we always keep in mind when we try to guide what our investigators are doing in their research. And we see solution-oriented research as this golden intersection, this triangle between the research idea driven by the investigator who's passionate about the research, the available data and specimens, and, as I was mentioned before, the needs of our end users. So what is the National Academy of Medicine saying? What is the U.S. Preventive Services Task Force saying? What are white papers and professional societies saying that they need in research that our investigators can fill? So it actually spurns the action. So it might inform programs like intervention studies, even in our intervention network itself, or public health programs like whole of community intervention programs. It might contribute to clinical practice guidelines. So the U.S. Preventive Services Task Force, which is tasked with recommending what our doctors do in primary care for prevention, often comes out and says there's insufficient evidence. How do we reduce that insufficient evidence? Or how do we contribute to policies that might be changes in state and national policy, regulation, or legislation to reduce risk or maximize benefit? So now I come to the advertisement for our first Science to Action Symposium, which is happening next week. And you're all invited to attend because there's a virtual option. The purpose is to bridge this gap between cutting-edge child health research, especially from the ECHO program, and actionable solution to enhance kids' growth and development. Our focus, you might not be surprised, is on early developmental influences, and we'll have 3 sessions, one on chemical exposures, one on social and neighborhood factors, and one on community experiences. And if you attend, you can have a way to connect with researchers, but not only researchers, policymakers, health professionals, advocates, media, to help some of these knotty issues in maternal child health. Here's the site at the bottom of the slide. I'll come back to that at the end if you want to, if you don't have time to copy it off this slide right now. You're welcome to attend. We already have more than 1,000 attendees signed up, but you're welcome to join us and hope you do. I also mentioned that we're making the data and specimens from ECHO available to the broad research community not just to the echo investigators. So as I mentioned, ECHO launched in 2016. We're now entering our 10th year. Our funding sites are in 42 states, but we have participants in all 50 US states, DC and Puerto Rico. There have been about 2,000 papers from ECHO cohort investigators, and we have this growing data and specimen resource. So for a few years now, we've made the data available through the NICHD Data and Specimen Hub DASH. This involves de-identified echo data. And so you can do an analysis of de-identified data by going to this site and doing a data use agreement. And the data use agreement is more of an administrative than a scientific review. So the bar for getting these data is pretty low. And in this controlled access public use database, we have data from about 71,000 participants. And it includes developmental data, demographic information, data on the environment, pregnancy and birth information, our outcome data, and data related to public health crises such as COVID-19. We do have small grants for US graduate students and postdocs, and we're really happy that the DASH data are being used. In addition, I'm just announcing now we have a new ancillary studies process. So this is for non-ECHO funding to get access to ECHO identifiable data and biospecimens. This is even a richer resource than the DASH data. And some of those identifiers that are really important include dates, like date of birth, and historical addresses. And many of our researchers have used the addresses for geospatial analyses, whether that be for air pollution or census tract data or crime or many, many other things. So we now have an ancillary studies process, which you too can access and start to use our more rich data and biospecimens. And we really think the biospecimens are going to be an amazing resource going forward and really expand the use of the ECHO data for greater impact. So what are my take-home messages today? We've tackled many challenges in our first 9 years. We now have one ECHO cohort that's poised for future success. Our fieldwork is going well. Our collaborations are very fruitful. Our data and specimens are now open to the broad scientific community, and here are the websites for both DASH and the Ancillary Studies program. And we're informing programs, practices, and policies through our solution-oriented research, as evidenced by our ECHO Symposium Translating Science to Action next week, and we hope you join us on the 15th of September. So to learn more, I would point you to the second resource here, which is our website, echochildren.org. There are many, many resources there. You're also welcome to email us, connect with us on X, or sign up for our newsletter. Thank you very much.
Thank you, Dr. Tillman. We have some time for some questions just before our coffee break. Yeah, you please. Okay. And also maybe Lucila, if you want to come here, please.
Professor Poston, I have a question for you. Using electronic medical records for research is really a rich resource, and it's being done all over the world. One of the keys in all cohort research is to use valid data. And with electronic medical records, which are collected for clinical or even in the United States billing purposes, a lot of times the data from the medical record are not as valid as we'd like, say gestational diabetes. So in your Elixir program, which is really wonderful, how do you tackle this issue of the validity of the data?
You're absolutely right. And so this is something which we've been working hard at. We redefine the outcomes of the questionable clinical diagnoses. So we've just done that for preeclampsia, and we've used the new recommendations for definition for preeclampsia, and we've redefined the diagnoses. So they are very available for people to use, and we use the redefined correct diagnoses. For gestational diabetes, we do the same thing as well. So we check them all, and that's where looking into the data, that's what takes the time. When you've downloaded the data, you're cleaning the data, you're checking the diagnoses. It is, I mean, it's also a hazard when you're doing cohort studies in the same way, because the diagnoses by some clinicians are not according to the current diagnostic guidelines. So you have to check and be careful about it. But yes, that's what we've been doing. And we're doing a big study of gestational diabetes at the moment with the adjusted diagnoses. Actually, the diagnoses for gestational diabetes are not that bad, because we have a separate diabetes and pregnancy service, which is very accurate. But the preeclampsia diagnoses are lamentably poor. But that's what I mean by feeding back to the health service. We are feeding this back to the providers and saying, your data is not really useful for diagnosis of preeclampsia. You can use these variables to get a very easy diagnostic, just have a collection of them, you can put them together and have the proper diagnosis. And we are feeding that back. So I think that is what I mean by improving the healthcare records, by feeding back to the providers for the correct diagnosis. But it's an habitual problem with everything that we do, I think, both standing cohorts and these dynamic cohorts.
Okay, you have time for questions. Just want to ask. Yes, it's because I don't know if my wire, I guess.
Thank you. I have also a question for Lucilla. I was wondering about coverage. So when you're looking at electronic records, who are we missing? Do we have any information about people who aren't seeking care and don't get into those databases, and how that might influence?
That's a very good question. Actually, that helps us again with management. We've just done this study of immigrants coming into the health service. Now, they're officially immigrants without recourse to stay in the United Kingdom don't get any health service funding, but they are allowed to come into the antenatal care pathway. And they're supposed to be billed for it, but they never are. But they come in late. So we can redefine that population. They're coming in late, they're getting poorer care, they're attending fewer clinical sessions. And the other thing is they're going, because they've been taken from one accommodation to another, they go between different providers. And so they don't have any continuity of care. So all those things we've been looking at, and that's given us very valuable information. So we get all the information of anybody who checks in. We also get the people who work who comes to the private sector as well. We can get that data from. So it's informing us a lot about who's getting good care and who's not, and who we're missing. And then again, feeding back. I mean, the paper we've just submitted to Lancet Public Health is exactly about that, and saying this is what the healthcare providers need to do. These people are very high risk. They're not being picked up. We're missing their data. And their pregnancy outcomes are lamentably poor. So it's yeah, but otherwise, I mean, it's pretty complete, the data that we're getting. Nobody escapes the net in terms of getting the data. Thank you.
Okay, just one comment. I've been advised now that our cough break is getting cold. Okay, so we are going to have one more question. Then we go to the cough break, and when come back, we can continue with questions on these same topics, but it's just because the staff there is already waiting for us. So your questions, and then we go. But of course, you also have the opportunity to approach to the speakers and to talk to them during this cough time, okay?
So good morning, everyone. I'm Diana from UFRJ, Rio de Janeiro. I don't know if Lucilla remembers me, but yeah, but we worked together a long time ago. So it's really nice to see you again. And I'd like to thank both of you for very nice presentations. I work in two very similar initiatives in Brazil. The first one using administrative data for the nutrition surveillance system. And another is a maternal and child nutrition consortium that harmonize primary data from individual studies around Brazil. And as you said, we have also a lot of difficulties in this process. And one thing that I would like to know, and from your experience, is how you deal with missing data, because it's a very important limitation for us, especially for the nutrition surveillance system. And we have like misinformation, very important variables, but also in the maternal and child consortium, because the part of the harmonization that the variables are not like similar, so we cannot combine them together. And sometimes the proportion of missing data do not allow us to impute. Yeah, and that's a huge problem for us here. And I'd like to know how you deal with it in your experience. And thank you.
It is a problem. I mean, it has to be said, it's the questions that we've been asking so far, we've got pretty good complete data, and you have to, if you're looking at the database, you can see where the missing data is. You'd be stupid to start a big study on the basis of those fields. So when we're developing the studies, we will look and see how complete the data fields are. But we do sensitivity analysis and imputation if we can. But as you're right in saying that sometimes it's and we report it obviously, but you just have to try and avoid the data fields which have got massive missingness. And again, feeding back to the health service providers and saying, look, these fields are not being filled. Actually, in the National Health Service, they do have to report a minimum service data set to the government. And those data fields, which are quite detailed, but they're not as detailed as the whole database, are very, very complete. But so if you're asking questions with that maternity services data set, they are going to get a lot of, well, very little missing data. It's when you get into the other data fields. So yes, we're moving now to the EPIC system, as I mentioned to you, and EPIC is going to be better. I think it's a much better system to use. There was, in the previous system that we had a lot of fields which duplicated the data, so you had to find out which field was being duplicated. That's all come out now. So I think we've got a clean data set going forward. It's going to be much easier. But this is where the time is taken by the individual researchers to look at the data in detail and to look at what's feasible and then impute if you can. But we'd rather have complete data, but it's always a problem.
Yeah, thanks for that question. It's so interesting that my answer from a cohort that is primary data driven is really the same as the answer from a cohort that's secondary data driven. And especially because in ECHO, we started with all these different studies, which have different designs and different variables, et cetera. So you can imagine that missing data is a huge problem with our historical data. So one of the ways we overcome this is you're going to EPIC, we're going to a standardized protocol. So in our newer data, we have many fewer missing data, but we're still left with the problem going back historically. And I would say the same thing, that our data analysis center, which has a lot of expertise in missing data, is working with all the investigators to harmonize the data that they can and come up with this set of derived variables that are what the investigators mostly use, and recognize that there are some variables right now that just aren't mature enough in their completeness to be used. Going forward, I think it's going to be less and less of a problem because of this more standardization. So I think upfront standardization is really key. I do think that on the back end, as you were talking about, there are these models to take disparate data and get them into a common data model so people can use them. That's the same as getting primary data into derived data variables in their data set. But it really behooves all of you who are going to start these studies to look around in your environment and to say, okay, what are other studies using? What's the gold standard? Where's a common data model? And sometimes it takes some compromises because you're not going to get every last piece of information you want on this variable, but the power of being able to use it in a big data set, especially as you combine it with other data sets, can overcome that and can really drive impact. So think about this up front when you're designing your own studies, whether it be primary data or secondary data. And I would say in ECHO's case, we share our protocol, our findings, and others share their protocols with us across the NIH landscape. And we'd love to do this more on an international basis. We just haven't had the time to put into that yet, but that's one of our goals for the coming years.
Okay, thank you. We're gonna have just a break now for our coffee break. It's just downstairs here from this building. We're just one level behind here, okay? And then we come back. We have a half an hour for our coffee break, and we can go back to these questions, the same session, okay? Okay, let's have a coffee now.
We will start here. That's the next one.
But
Be here.
please come back, not just stay there for longer. It's okay.
Hi, everyone. So we are going to start in a few minutes. I hope you had a very good break and coffee. And we are going to open again for some questions. Very briefly, we don't have much time, but yeah, so feel free to continue the questions. And I think we can, Natalia? I don't think Natalia is here. Okay, I can do it. Okay.
So we restart after the lunch, after the coffee break before the next discussion. We continues, and I remember that we will have a question here, and Beatriz would be here just to everybody listen to you.
Hi, thank you both for your beautiful lecture. Professor Gilman, about these preconceptional factors that influence child health, I was curious about which kind of questions and data are you asking for the father and partners?
Thank you for that question. I was just chatting with Lucilla here about recruitment of partners. It's a challenge to recruit them. I won't talk about those challenges as much as the data we want to collect. So we are aiming to collect very similar data from the fathers as we do from the mothers. So in addition to sociodemographics, we would get information on their lifestyle factors. So that could include diet or physical activity or sleep. We're getting some information about their toxic environmental exposures, a little bit about nutrition. So those kind of factors. So social, demographic, lifestyle, behavioral, and environmental. In addition, we are collecting semen to specifically look at epigenetics in the sperm. And we've just started that. We're doing a pilot right now about collection and processing so that we might be able to do that on a nationwide basis. And, we're going to see what the feasibility is. In addition, we're collecting blood and urine. So we hope to have a large range of survey information as well as biospecimens. Does that answer your question? Yeah. Lucilla is asking about mental health data. We won't have so much about the history of violence, but we will have information about depression and anxiety.
We can continue. More questions? Open your hands. Here. Could you go?
I don't think the
Just because the people are needing to listen you. Thank you.
Hi, my name is Angelica from the UFPR. I'm working on human genetics, as I told you. You were talking about depression, anxiety. How are you measuring this? Is only self-reported, or is there any psychometric measure? So are you using scales like Beck anxiety or depression of Beck or whatever?
Thank you for that question. There's a a movement in the US to collect these kinds of data from a system called PROMIS, P-R-O-M-I-S, and I forget what that stands for. But it's a kind of measure where you can use, what's it called when you ask certain questions and then you can ask the next questions based on the answers to the first questions? There's a name for that. It's adaptive questioning using item response theory. So those measures use that kind of approach. And it's about depressive symptoms and anxiety symptoms, not so much about the diagnosis. We do, however, ask about doctor diagnosis of certain illnesses, and they're included there as well.
Okay, that's fine. So I'm doing it too.
More questions? We have time. Here. Please, because I think centralizate this is possible. It's easy.
So, Matt, this isn't a question that I asked Linda during the break, but maybe you can speak to it as well. Given the drop in fertility, total lifetime fertility that has occurred and is continuing to occur, can you speak to, I mean, you know, half of all births in the United States now are preemies. Just about, right? Not premature, first births. Right? Premips.
I thought you said
No, premips. Right? So can you speak to the conditional likelihood of a baby being born to a mother who has had a child already? Presumably that decreases with parity, right? So the feasibility of recruiting inter-pregnancy for a preconception of the next child cohort and what the numbers look like for that.
We have an expression in English called the proof of the pudding is in the eating. So that's by way of saying we will find out. The data we're going on are from the National Children's Study from about a decade ago, in which we're able to forecast the likelihood of having a second pregnancy in the first 6 months, 12 months, 18 months, etc. And we're guessing that we will have, for every 10,000 preconception participants, about 3,000 pregnancies. We shall see.
We've been thinking about this with the data linkage cohort too, where we can identify second pregnancies because they have a different code. So we will be looking eventually at outcomes from first and second pregnancies, and intervals between them, I think, is very important. That the length of time is important, and if a change of partner is involved, it's more difficult to find that out. But it is something possible that you can do with these with the data linkages to look at subsequent pregnancies. Yeah. The mental health question, yes. So we similarly to the ECHO cohort, we have in the antenatal care, we have the Edinburgh Postnatal Depression Score, which is actually used in antenatal care, and that's something called a Hooley score, which is also gives us an idea about anxiety and depression. But because we're working with the general practitioner, that's the community doctors, we will get diagnoses of depression and also referral to the mental services, which is useful. So if we know, we're looking at the moment as those who are referred, who gets care, and then what their record is in the mental health trust. So we're picking up the people who have more severe mental illness that way. Yeah.
More questions? Here.
Good morning, Professors Lucila and Matthew. I was very inspired by both presentations, and it's amazing all that you can do, all the data that you're being able to bring together in the UK, in the US, and that's very fascinating. My name is Teresa. I'm Brazilian, but I've been living in New Zealand for 10 years, and there I work with the Growing Up in New Zealand cohort data. So just a question, again, in mental health, because maybe I didn't follow everything. I'm just curious about the variables of symptoms of anxiety and depression. Is that only for the moms or also for the children? And if it's for the children, from which age are you collecting that information?
Yeah, we're doing it, sorry, Mac, we're doing it for both the mother and the children. So we are picking up children who have symptoms of autism and ADHD at an early stage up to, well, from about 2.5 to 3, the earliest, and their records are being incorporated as well. So we're looking at the relationship between maternal mental health and child mental health referral to see what it's all about if we can. But yes, we're picking them up, children up as well. Matt.
Yeah, thanks for that question. To expand this a little bit, our cohort measures the child behavior checklist, both in the preschool and the school age. So that gives you internalizing and externalizing behaviors that tend to predict some of these outcomes. And then at school age, starting with the promise measures of depression and anxiety throughout adolescence.
Thank you so much. Can I just ask one more question, my personal interest for both presenters? I would like to know a little bit about which information you have in terms, if you have information on children's diet quality, especially looking within those first 5 years of life specifically.
Well, for the moment, we don't have that. So that is I think we're just saying that in the break, that the lack of nutritional data in the routine healthcare data is a sad omission. So we are hoping to persuade the health service to add some questions, especially to the antenatal data, a few questions, and the health visitors some nutritional information. We get breastfeeding, and we also get information about post-weaning feeding already from them. So we have a little bit of that, but it's not adequate enough. We are just getting ethical permission to ask our people who are giving us blood samples to do intake 24, which is the program which is used in the United Kingdom. And so we're just doing that right now. So hopefully we will get a subgroup who has really good dietary data. Oh. But it's an issue about routine data, is that there's not enough nutritional information in it.
Wonderful. Thank you.
So historically, our cohort sites measure diet in very different ways. Some during pregnancy, some childhood, some both. Going forward, we have standardized measures of food frequency questionnaires in pregnancy. And I'm probably going to get this wrong, and Linda, you may know more about this than I do. But in addition to infant feeding practices, we also have data about the mother-child interaction with feeding. And we have data on intake starting in the preschool with more brief FFQ type instruments.
Thank you very much.
We have time for 1 or 2 questions more.
Hello, good morning. Thank you for your presentations. Was great. My question is not exactly related to cohorts inside an unique country, for example, the UK and US, but thinking at global level, how to address race ethnicity variable, because it's a huge challenge to standardize this variable. And maybe I think that some paths are exclude this variable when harmonizing or considering the country and region, not the race ethnicity variable. But I would like to hear, based on your experiences, how can we overcome this challenge?
Thank you for this question about race ethnicity. It's really a huge question. And I think before we talk about the measurement of race ethnicity, we should talk about why we want to collect it. And, so many people have thought of race and or ethnicity as a biological variable. And now we really know it's a social construct. And we should all think about that first as a social construct. And as a social construct, we have certain questions we might want to ask about what underlies an association of race ethnicity with an outcome. Then we know a little bit more about how to measure it. And I would say that it would be very difficult to standardize race ethnicity across the world because these questions are so different in different places in the world. Even within the US, there are big I would say, controversies over how to measure race and ethnicity. And no matter how we do it, there's going to be some pros and some cons. So currently in ECHO, we measure this in a multi-part framework, starting with race and including different ethnicities under that, and including sub-ethnicities under those ethnicities. So it's pretty detailed, and I think it will give our investigators a chance to, again, look behind these race ethnicity variables to what's driving them, whether it's structural factors or other factors. So I think everyone could have a discussion about this. It's really a rich, very rich discussion. Lucilla?
Yeah, I can only agree. I mean, it's a really difficult problem. We have WHO definitions, which is a very long list, which is what is collected. We also collapse that in most studies to in the United Kingdom to white, black, Asian, or other. Because I mean, what do you do, and how useful is it? Because it is a construct, generally, not necessarily a construct of socioeconomic status and the parallel, but not with everything. I mean, cultural, nutritional side of things is ethnically related. So it's an unanswered problem, to be honest with you. We've tried it every which way we can think about it. We actually discovered in the United Kingdom that the government statistics were incorrect, in that they were using British as meaning British of any origin, that's black, Asian, or anything else. And the statistics were being reported incorrectly. So that's at government level. So that's the sort of problem that we have, because people are saying they're British, whether they're black, Asian or not. But in fact, we're talking about white British, most people. So we get confused. So we don't have an answer. Very difficult one. Thank you for asking it.
I wanted to clarify my answer. I didn't, if I was unclear about this, I did not mean to conflate race and ethnicity with socioeconomic status, only to say that race and ethnicity could reflect a social construct such as racism, which would be different from socioeconomic status.
Mm-hmm.
So again, it's really important to think about what we mean by those variables, and that tends to help us measure them. And our measure of race and ethnicity in ECHO is now based on the WHO standard, but it's also filtered through our Office of Management and Budget and then down to our level. So,
Marty, would you like to complement something? I saw your hands.
I would like just to say before questions, just tell about your name, introduce her case. Just Helena, and she's a PhD student, right? In Federal University of Rio de Janeiro. But maybe just going back to about race and ethnicity, this is a big issue. Yeah, I know, I agree with you. Yeah, we have no answers exactly, but if we don't do that, or if we don't stratify our study populations, we cannot address health inequalities. So this is why, because when I was in Portugal last year, and they told me, because in Portugal, they cannot, even the health system there, they are not using this question in the health services about your skin color or ethnicity, because they said, oh, this is not legal, this is not appropriate. So how to address this? And they are not thinking the way, but the health inequalities does exist, do exist there. And if we don't address this in research and in health data, health systems data, we cannot just face this problem.
Sure. So if you don't have more questions, I think we're finishing our first session in this wonderful meeting. Thank you so much, Professor Postum, Professor Dilma, for this wonderful talk and the interaction and questions and answer of the audience. We will continue now. Thank you so much for both.
Thank you very much. And now I would like to call Professor Cecilia and Teresa, who are going to run this abstract section, please. And I ask kindly to all the presenters to prepare.
On the Federal University of Maranhão. As I said, I'm coming from New Zealand, and it's a pleasure to chair this session. I would like to, I think we need to control the time, Marli. Should we control the time? Yeah, are you? Because maybe when it's missing more or less 2 minutes for the, we can, are you happy? Okay, wonderful. Thank you so much. So it's a pleasure. I would like to invite for the first presentation of this session, Giovanna Nigri Cursino, who is going to be presenting the work Sociodemographic Factors are Associated with Gestational Weight Gain Trajectories, Results from the Brazilian Maternal and Child Nutrition Consortium.
Good morning, I'm Giovanna Cursino. I'm a nutritionist and PhD student in nutrition at Federal University of Rio de Janeiro. My advisor is Professor Diana Farias, and my work is entitled Social Demographic Factors are Associated with Gestational Weight Gain Trajectories, Results from the Brazilian Maternal and Child Nutrition Consortium. So first of all, I would like to declare that none of the authors have any conflicts of interest. So gestational weight gain is essential for proper growth and development. So when the gestational weight gain is above or below the recommendation, is associated with a lot of adverse maternal and child health outcomes, such as cesarean delivery, postpartum weight gain retention, small for gestational age, or large for gestational age, and preterm birth. And there's some factors that is associated with inadequate gestational weight gain during pregnancy, such as maternal education and age or race ethnicity, household income, pre-pregnancy BMI, smoking, parity, dietary intake, and health conditions like diabetes or hypertension. However, it's not only gestational weight gain that can impact on adverse outcomes, but the trajectories of gestational weight gain also can impact. Like, for example, this Malaysian study identified 3 trajectories. Here we can see the first trajectory, the blue one, is with a slow initial gestational weight gain, followed by a drastic gestational weight gain during the pregnancy. And there is association with women who has more than 30 years and women with incomplete secondary education, with low education. So the aim of my study was to identify gestational weight gain trajectories according to the Z-score of the Brazilian gestational weight gain chart and the association of social demographic factors with these trajectories. So this is a longitudinal study that used data from the Brazilian Maternal and Child Consortium that included 10 Brazilian cohorts between 1990 and 2018 from across 24 Brazilian states and the federal district. So our criteria was adult woman with singleton pregnancy without a diagnosis of chronic hypertension or pre-pregnancy diabetes, without a diagnosis of pre-pregnancy disorders, and women who had information on gestational age at visits and social demographic variables. So this is our flow chart of study population selection. We initiate our database with 2,500 women, and we did our steps of exclusions, and our final database contained 1,000 women. So our variables were pre-pregnancy weight, height, pre-pregnancy BMI, cumulative gestational weight gain, gestational age, and social demographic variables like maternal age, maternal education, and maternal race and ethnicity. So our statistical analysis were the gestational weight gain trajectories were identified using latent class growth modeling. And then we did the associations with the social demographic variables using multinomial logistic regression. All the analyses were performed using STATA and ER. in our, yes. So here is our results. Here it's our figure U1 with the trajectories of cumulative gestational weight gain according to the score. We see 4 classes. So the first one is the blue one, titled decreasing, the decreasing trajectory with a high gestational weight gain and a decline across pregnancy. The second trajectory was the stable increasing, the purple one or red. I don't know if what color did you see, but the stable decreasing, we see a stable increasing during all pregnancy. It's our reference category. And the third trajectory was the stable decreasing, the orange one, with a stable decreasing during all the pregnancy. And the fourth trajectory was the increasing one. It's the green line with a high gestational weight gain during all pregnancy. So here it's our first table. It's the association between gestational weight gain and race. So here you can see that Black women had higher risk of being in the trajectory 1 and 3. This is our second table. That's the association between the gestational weight gain trajectories and maternal education. Here we can see that women with less than 8 years of education had higher risk of being in the trajectory 1 and lower risk of being in the trajectory 4. In our third table, we see the association between gestational weight gain and maternal age. Here we can see that women who are aged 25 years or less had lower risk to be in the trajectories 1 and 3 and higher risk in being in the trajectory 4. And we can see the inverse association in the women aged 35 years or more, that they are higher risk in being the trajectory 1 and 3 and lower risk in being the trajectory 4. So in conclusion, we can see that monitoring gestational weight gain is crucial part of prenatal care, and the social demographic factors like maternal race, age, and education are associated with cumulative gestational weight gain trajectories, but we need to have more studies to identify the trajectories based on the Z-score of the Brazilian new curves and to examine their association with social demographic factors and maternal and child outcomes. This is our findings, the references. Thank you so much for your attention.
Thank you very much, Giovanna, for your brilliant presentation. We're going to have some questions for you at the end. I would like to now invite our next presenter, Caroline Zani Rodrigues, who is going to be presenting the work Intergenerational Malnutrition Profiles in the Brazilian Amazon, Characterization and Predictors in the First 2 Years of Life.
Good morning, everyone. I'm Caroline. I'm a PhD candidate here at School of Public Health, and I'm going to present now part of the results of my PhD thesis about the characterization and predictors of malnutrition profiles in the Brazilian Amazon during the first 2 years of life. The coexistence of under and overnutrition parameters are known as the double burden of malnutrition, and it can occur at the population, household, or individual levels, and are included in the definition parameters of undernutrition and overnutrition considering anthropometric and biochemical information. So early childhood is a crucial phase for promoting healthy growth trajectories, appropriate eating practices, and to prevent diseases. However, there are important knowledge gaps regarding the double burden of malnutrition in this age group. We have a systematic review of operational terms on the double burden of malnutrition that present results showing that only 14% of studies on the double burden of malnutrition included the occurrence of anemia or micronutrient deficiencies, and 9% focused on the double burden of malnutrition in the household level, considering the mother-child pair, and only 1% of the included studies in this systematic review were performed with longitudinal designs. So understanding the double burden of malnutrition from an intergenerational perspective, considering also multiple malnutrition parameters aside from using only anthropometric variables is important, especially regarding the evidence that exists on the repercussion of early life malnutrition, such as worse school performance, reduced physical strength and work capacity, inadequate development of organs to the benefit of the brain development, and increased risk of developing non-communicable diseases throughout life. Also, considering the complexity of the definition of the double burden of malnutrition, it is interesting, it's important that we consider not only anthropometric variables, because it could be a bit limited. It could underestimate estimates and repercussions of the phenomenon. Therefore, we should focus on more studies, including biochemical parameters of malnutrition. And also the study of the phenomenon would benefit very much from using more robust analytical approaches that would provide more flexibility in identifying patterns in the data, and not only combining malnutrition indicators arbitrarily. So the main objective of the study was to identify if there were different patterns of malnutrition in the mother-child pair up to 2 years of age, considering anthropometric and biochemical parameters. And the secondary aim was to explore predictors of the malnutrition group patterns in this group. This is a longitudinal analysis conducted within the maternal and child health and nutrition in Acre, the Minas Brazil study. It is a population-based birth cohort in the Amazon region. It is conducted in Cruzeiro do Sul city in Acre state. And between 2015 and 2017, data were collected on socio-demographic, health, and lifestyle characteristics. And nutritional status of mothers were assessed by maternal BMI. And nutritional status of children was assessed according to the World Health Organization growth standards as height for age and BMI for age. And child's blood samples were collected to measure hemoglobin, ferritin, and vitamin A concentrations. We performed latent profile analysis to identify different malnutrition profiles. We used as model fit indices Bayesian information criteria, low Mendel-Rubin test, in addition to entropy, and then performed multinomial regression analysis to identify possible predictions of the malnutrition latent profiles. And all analysis was conducted in the software M+. Well, so in order to identify such possible patterns, we conducted 5 models using continuous maternal BMI, child's height for age, and BMI for age, Z-scores, hemoglobin levels, ferritin, and retinol concentration. So we estimated 5 models. The first model tested for separation of only one profile in the sample. We did so on to 2 profiles, 3 profiles, 4 profiles, and the last one we tested for separation of 5 profiles in the sample. So here we have a graph showing an Abel plot, and it shows model fit indices for all the different 5 models. And the red arrow shows the model in which increasing the complexity of the model, meaning increasing the number of profiles, did not yield equivalent decreases in model fit criteria. Therefore, we chose the model with 3 profiles, as it showed acceptable goodness of fit, and also regarding interpretability, considering the nutritional status indicators. So here we have the results of those three profiles separated. The first one is the least prevalent, with 5% of mother-child pairs. We named it as iron-deficient children because we had here mean ferritin concentrations of 5.7 microgram per liters, with the confidence interval below the considered cutoff for iron deficiency. And the hemoglobin concentration followed this trend with a lower mean. The second profile, we named it adequate pair, and it is the most prevalent profile with 86% of the mother-child pairs. And we call it that way because most of the nutritional indicators were according to what is considered adequate. And at last, the third profile, we named higher maternal BMI and child BMI for age. We can see that mean maternal BMI was 28.6, and the confidence interval is above what is considered the cutoff for overweight, and mean BMI for age of 1.96 scores. And the confidence interval is also above what is considered by World Health Organization as risk of obesity for this age group. And we also can see that height for age is also higher in this group. So we can understand that they also have higher linear growth. And here we have the results for the predictor analysis. And the chance of belonging to the first profile, the iron deficient children profile, decreased 69% for each increase of 1 year of maternal schooling. And this chance of belonging to this group decreased 72% with each increase of 1 point in the household wealth index. Conversely, for the chance of belonging to the third profile, this chance increased in 28% for each kilogram per meter square pre-pregnancy maternal BMI, and increase in 98% for each birth weight Z-score. As final remarks, we found 3 distinct mother-child nutritional profiles in this population, being adequate pair, iron deficient children, and a group of higher maternal BMI and child BMI for age Z-score. The chance of belonging to the iron deficient children group was predicted by maternal schooling and household wealth index, and the chance to belonging to the higher maternal BMI and child BMI for age Z-score was predicted by pre-pregnancy BMI and birth weight Z-scores. Thank you very much for the opportunity. I would also like to declare that the authors have no conflict of interest, and I also want to thank São Paulo Research Foundation for the support. Thank you.
Thank you, Caroline, for another brilliant presentation. Our next speaker is Andrea Machado Miranda. She's going to be presenting on the social inequalities in leisure time and transport-related physical activity through the lens of intersectionality. Anyway, you can read there. It's not going to work. Evidence from a 10-year longitudinal study in Brazil. Thank you, Andrea.
Hello, everyone. Good morning. Bom dia. Thank you for being here. It's a pleasure to be a part of this symposium and share with you. It's better now. So it's a pleasure to be part of this symposium and share with you our main results. So my name is Andrea Miranda, and I'm a researcher at the University of São Paulo. And the title of our project is Social Inequalities in Leisure Time and Transport-Related Physical Activity through the Lens of Intersectionality, 10 years longitudinal study in Brazil. So the authors declared that they have no conflicts of interests. Hence, as we know, physical activity is essential for health and a key for preventing chronic diseases, special mental health, and enhancing quality of life. However, physical activity levels in Brazil remain low, especially in physical activity in leisure time. Leisure time and transport physical activity are shaped by different social factors such as race, sex, education, income, and also urban segregation. So in São Paulo, the most populous city in Brazil, built environments and this social spatial segregation exacerbates the disparities in physical activities, with barriers such as crime, poor lighting, inadequate sidewalks, and the lack of safe leisure spaces. So physical activity is unequally distributed across social groups. To date, we know that most research is cross-sectional and comes from high-income countries. So this highlighting the need for longitudinal studies, evidence from the Global South using an intersectional approach. So in this context, our study aims to explore social inequalities in both leisure time and transport physical activity through the lens of intersectionality among individuals living in São Paulo. For this study, we used data from the HISA Physical Activity and Environment, a prospective study. We have 3 waves of this project. So we have the baseline, the second wave, and the third wave. And for this study, we use the data from the 978 people who participate at the 3 waves of the study along the 10 years. So all data were collected through standardizing and structured questionnaires. And to assess the outcome, the physical activity, it was used a long version of EPAC, and the classification was in yes or no. So people who practice more than 10 minutes per week, or people who don't practice any kind of physical activity. Regarding to socio-demographic and lifestyle variables, we used the age, marital status, employment status, BMI, and sedentary behavior. And in relation to exposure, the DOHaD index was constructed based on the combination of the 3 socio-demographic variables, such as sex, education, and race or skin color. So, specifically for the construction of DOHaD index, this index is based on the theory of intersectionality. So this captures cumulative and social inequalities based on multiple combinations of sex, race or skin color, and educational level. So the points 0 and 1 that you can see in this table were headed for each variable, so for sex, for race, and for educational level, and the index score, it ranges from 0 to 4, where 0 represents no vulnerability, so the category of male, whites with higher education, and the category 4 represents the maximum vulnerability, so female with Black, brown, and indigenous with lower education. So the higher values of this index indicates the greater social vulnerability. We conducted statistical and descriptive analysis to examine the distribution of these socio-demographic factors and physical activity in leisure time and in transport related across the 3 waves of the study. to investigate the association between Jeopardy index with leisure time and with transport-related physical activity, we're using multi-level Poisson regression analysis, estimating the prevalence ratios. So the models incorporated 3 levels: the census tracts, the individuals, and the observation in the 3 waves. And all the analyses were conducted in the 3 stages. So 1, crude models, models adjusted for time, and 3, the fully adjusted models with sociodemographics, BMI, and sedentary behavior. And all the analyses were performed in the software STAP. And up next, I will present our main results. So this figure shows the frequency of leisure time, physical activity, and transport-related physical activity among the 3 waves. So we can see that in these 2 types of physical activities, there is an increase across the waves, especially in the leisure time. And now these graphs show the prevalence of leisure time according to Jeopardy index across the 3 waves of the ESA study. So in the first graph on the left, we can see the results on the baseline following the 2nd wave and the 3rd wave. So we can observe differences between the extremes in all waves. So the group with score 0 in the Jeopardy index, so the less vulnerable group in green, has the highest levels of leisure time physical activity, and the group with score 4, so the most vulnerable group in red, has the lowest levels of leisure time physical activity. So the greater the social vulnerability, the less physical activity in leisure time. And these other graphs represent the prevalence of transport-related physical activity according to the Jeopardy index in the 3 waves of the study. So we can observe that the differences in transport-related across social vulnerability groups were less pronounced than in what was observed in the leisure time. So there was an increase similarly in all groups, the least vulnerable and the most vulnerable, from the baseline to the wave 3. So in all waves, there were no significant differences in transport-related physical activity between these groups. So I'll do some variations where observed. The lack of statistical significance suggests that transport-related physical activity was relatively stable over the time. And to finish the results, this table shows us the association between the Jeopardy index and the physical activity domains over the 10 years of follow-up. So we can observe that over time, participants in the Jeopardy categories 3 and 4, so the most socially vulnerable, had significant lower prevalence of leisure time physical activity compared to the reference group. So the category 0 of the Jeopardy that represents male, white, and highly educated. In contrast, no significant associations was observed between the Jeopardy index and the physical activity domain in transport related. So according to these results, we can conclude that persistent and widening inequalities in leisure time physical activity were observed among Brazilians over a 10 years period, with intersections of sex, race or skin color, and education disproportionately affected the most vulnerable groups, particularly females from racial or ethnic minority groups with lower educational levels. So these findings underscore the urgent need for equity-focused policies and target interventions to ensure inclusive access to physical activity, especially in the most socially vulnerable populations. So the Health Survey of São Paulo, Physical Activity and Environment, was supported by the FAPESP, and I received the research fellowship from the Bridge Global Health Partnership. And here are some references using in this presentation. And thank you very much for your attention.
Thank you very much for your presentation, Andrea. Our next speaker is Nara Brito. Is Nara there? Nara is going to be presenting prevalence and associated factors of suicidal ideation in adolescents at age 18, the 2004 Pilotus birth cohort.
Okay. Hi, good morning, since we haven't launched yet. So I'm a PhD candidate here at the Collective Health program in the School of Medicine. And I'm presenting today this preliminary results from my PhD, the prevalence and associated factors of suicidal ideation in adolescents at age 18 in the 2004 Pilotus birth cohort. First of all, we have all the authors have no conflict of interest, and I had no funding for this study. So just to have this background on suicidal ideation, it is a part of the spectrum of suicidal behaviors. It reflects significant psychological distress and requires specialized mental health care, particularly increasingly prevalent in adolescents and people with vulnerabilities and limited psychosocial support. So the suicidal ideation is the recurrency of thoughts about your own death. And it varies in intensity and frequency, ranging from passive to active ideation. It does not necessarily imply progression to death by suicide, and it's more related to mental health conditions. And its determinants are related from complex interactions among biopsychosocial, socioeconomic, and relational factors. The global prevalence of suicidal ideation is for all ages is between 10 and 14%. And in a recent publication from this global school-based student health survey in 82 countries, we found that 14% of the adolescents from 12 to 17 years old had related suicidal ideation. And this number goes to 16% in the Americas. We also have this a similar study here in Brazil, the PENSE, and 21.4% of the adolescents from 13 years to 17 years related suicidal ideation in Brazil in the last study, which was in 2019. And I'm bringing the data from Rio Grande do Sul because it's related to the city of Pelotas, and it was about 19.7%. It's important to note that the global school study takes the number from the last 12 months prevalence, and the PENSE is about the 30 days prevalence before the questionnaire. So the consequences of suicidal ideation are the deepening of the vulnerabilities, the diminished quality of life, and progression of mental health problems. And we come to the study with some premises. The first is the importance of investigating this topic in low and middle income countries. It's a topic that is mostly studied in Europe, United States, and its potential to contribute to mental health problem prevention in Brazil for this age, and the promotion of social emotional development from early life stages. So we sought to investigate the prevalence, distribution, and risk factors associated with suicidal ideation among 18 years old participants of this birth cohort. And for our methods, we used, for our main outcome, we used the mental health questionnaire applying during this last wave of the cohort. With this primary question, I think about killing myself, and we analyze as a binary categorical variable, and we also study multiple exposure variables from the perinatal assessment until the 18 years assessment. Here you can see all the follow-up moments that we have from 2004 to 2022, when we had the 18 follow-up moment. And it's a cohort that we have a very high follow-up rate. For our outcome in particular, not all respondents from this last wave responded to this question. It's a sensitive question, and some chose not to respond it. So the prevalence of suicidal ideation in our population was nearly 7%. I think it's most related to being a difficult question to be answered, since the most high indices of suicide in the country are in this state. So I'll present just some of our preliminary results. From the characteristics in the perinatal follow-up, we can see that the maternal racial self-identification was associated with our outcome, but only what came to our eyes was the yellow or Asian moms and indigenous moms. Also, the participant sex, so the adolescent being a female is highly associated. We didn't see the maternal age or the participant skin color, but the sex. We had like multiple moments of assessment of maternal depressive symptoms, and some of these stages were related to our outcome. Also, the child development at 48 months of age, the lower child development quartile was related to, and also stressful events at age 11. Also, gender identity, mainly consider the adolescent considers it's herself or himself, both men and women, and I don't consider myself any of them, being non-binary gender identity, LGBT sexuality, and also a bad or a very bad sleep quality. Also the use of tobacco and cannabis, but not alcohol. And for the 18 years of age, we found that stressful events, so the more stressful events they have, the more diversity in family relationships, and the more the level of stress, they're related with suicidal ideation at 18. And also some of dimensions of social emotional development, like locus of control, emotional control, and self-esteem. So the lower self-esteem they have, more related to suicidal ideation, the less emotional control and the more external locus of control are related to this outcome. And also the victimization by violence ever in the life, and the perpetration of violence too. So already told you, we've found like almost 7 prevalence of suicidal ideation, and our significant associations were female sex, non-cisgender identity, poor sleep quality, sexual minority status, maternal racial self-identification, maternal depressive symptoms, exposure to stressful events during childhood and adolescence, and adversities in family relationships across the life course. So our main findings so far is that the individuals that experienced the suicidal ideation, they had also experienced greater adversity, stressful events, threats, and low family support from the prenatal period until the 18 years of age. And this is our bibliography. And thank you.
Thank you, Nara. Thank you very much for your presentation. I would like to invite now our last speaker for this session is Natália de Oliveira Silva, who is going to be presenting multimorbidity in childhood and adolescence and its association with social-emotional skills in early adulthood, a study based on the 2004 Pelotas birth cohort.
Well, good morning, everyone. My name is Natália Silva, and my advisor is Dr. Alicia Matsashevich. Sadly, she's not here today with us, but probably tomorrow we're going to be able to meet her. And our research is about multimorbidity in childhood and adolescent and its association with social-emotional skills in early adulthood. And we also use the Pelotas birth cohort of 2004, like my previous colleague. Well, as we know, over the past decades, we saw changes in health and pattern. We saw, for example, a decrease of communicable disease on death related to communicable disease to an increase to death related to non-communicable chronic disease. And when it comes to that, multimorbidity became a key part of this team. Multimorbidity refers to the coexistence of two or more chronic physical and/or mental health conditions in an individual with none considered primary. This last part is very important because it will set the difference between multimorbidity and the concept of comorbidity, which refers to any condition additional to an existing disease, which will guide us to try a less segmentation of healthcare and a more coordinated multidisciplinary approach. But when it comes to chronic non-communicable disease, there is a lot of studies about adults or older adults when it's talking about chronic disease and, of course, about multimorbidity. And we still have a very scarce number of studies when it comes to children and adolescents. But we did bring some. And for example, the study in Ontario, Canada, they found a prevalence of 5.4% of multimorbidity, and they also found an association with mental disorder. I study in China with students between 6 and 18 years old. They found a prevalence of 53, almost 54 of multimorbidity. In Denmark, in a national study, with people between 14 and 26 years old, they found a prevalence of 20% of multimorbidity. And also those adolescents and adults who reported multimorbidity, they were also associated with 52 more chance of low well-being, more chances of suicidal idealization, and self-harming. Here in Brazil, we did have a study who searched about that. In the 1993 birth cohort study in Pelotas, Brazil too, they found a prevalence that increased from 26% at 11 years old to 44% at 22 years old. But overall, we still have very scarce literature about it. And as you can see by the numbers, there's important difference between the prevalence that were found on the studies. And this happens because there is no consensus of which disease to consider to compose multimorbidity. So some studies will consider, for example, dental caries. Some studies will consider mental illness. Some studies will not. So this will lead us to this big difference of prevalence between the studies. And as we know, childhood is an important moment of formation of identity, autonomy, and interpersonal relationships, and approach for similar groups, and of course, all the stages of puberty. But in all of these events, we lead the kid and to develop social emotional skills. But what happened when multimorbidity comes to the scene, bringing with it chronic use of medications, dietary restriction, higher frequency of hospitalization, and sometimes even altered development? This is basically our main question here. So for social emotional skills, we are considering locus of control, self-control, emotion regulation, and peer relationships. Locus of control is the capacity of realize the results of actions taken as a consequence of personal effort or as a product of lucky, of destiny. Self-control, to take responsibility for regulating the manifestation of your own desires, behaviors, emotions, and thoughts. And emotion regulation is the management of reactions, prioritizing self-preservation and equal well-being of peers. And peer relationship will be construction of bonds based on cooperation, mutual respect, and constructive conflict resolution. Our objective is to identify the presence of physical and mental multimorbidity at ages 6, 11, and 15 among participants of the 2004 Pelotas birth cohort, and its association with social emotional skills at age of 18. As I said before, we used the Pelotas birth cohort of 2004. There is a cohort who were made in the state of Rio Grande do Sul, Brazil, that is in the south of Brazil. And all live births in Pelotas at 2004 were recruited to participate of the cohort, and they had follow-ups at 3, 12, 24, 48 months, and at 6, 11, 15, and 18 years of age. An important part about the 15 follow-up is that it was made at 2020. So it was surpassed by the COVID, and that leads to just half of the participants at the cohort was able to be assessed by the time. So exposure of interest is the presence of multimorbidity at 6, 11, and 50 years follow-ups. And we consider the illness that we had asked in the questionnaires that were made at the follow-ups, which was obesity, high blood pressure, mental health disorder, asthma, bronchitis, and hearing difficulty. The social emotional skills at 18 years old, locus of control, emotion regulation, self-control, and peer relationships. And each of these skills are measured in a different way. So for example, locus of control, which higher the score, it means a more external locus of control. So that children that considers that the things that happen to them is a consequence of destiny or lucky, and which lower the score, a more internal locus. For emotion regulation and self-control, they both work similar, which higher the score, more emotional regulation or more self-control, and the opposite for lower scores. And to peer relationships, that is the only categorical variable. Results lower than 4 means more difficult, and higher than 4, less difficult. So we did find a prevalence of chronic disease of 15 at 6 years old, 32 at 11 years old, and 14 at 15 years old. We did a crude analysis, and also after an adjusted analysis by socio-demographics and perinatal variables that results in a p less than 0.20. And we found that multimorbidity at 6 years old and 11 years old were significantly associated with higher scores of locus of control, which mean a more external locus, lower scores of emotion regulation and self-control, and higher scores of peer relationships or a higher odds ratio or more difficult. Okay, so 15 years old, you only find significant association with emotion regulation and peer relationships. We also did a search about the presence of multimorbidity between 6 and 11 follow-ups. And we can see children that only have multimorbidity at 6 years old were 5%, only at 11 years old were 22%, and at 6 and 11 years old were 11%. And as we didn't have the full cohort for 15 years, we tried to focus on 6 and 11 years old follow-ups, and we saw the persistency of multimorbidity resulted in worse outcomes at 18 when compared to previous categories in all 4 skills. So children with multimorbidity, both at 6 and 11 years old, had worse outcomes than children that only had at 6 or only had at 11 years old. Well, this study was supported by Brazilian Coordination Educational Personal CAPS through a master scholarship granted to the author, and we declare no conflict of interest. Thank you.
Thank you very much, Natalia. We would like to invite now all the speakers to come to the table for some questions. Thank you. I think we can open for the public first for questions.
Hello, my name is Ana Beatriz. I work with data from Pelotas birth cohort also. Natalia, congratulations for your presentation. I have 2 questions. One, which is the causal pathway from socio-emotional skills to multimorbidity that you have thought about? And the other one is which diseases, I don't know if you put in the presentation, but which diseases were considered for this variable multimorbidity?
Yes, we did consider the disease that we had available in all the 3 follow-ups because the questionnaires were different in between the follow-ups. So some disease were questioned in the 6, but not at 11, at 15, but not at 6. So we had to focus on the ones we had in all of the 3 of them. And we considered obesity, asthma or bronchitis, hearing difficulties, and mental illness problems, which we assessed through SDQ questionnaire. Yeah. So we use what we had available on the all of the follow-ups, but some diseases were left out, which we didn't like that much because, like, for example, allergies problems, and that we wish that we could have considered, but we didn't have the 3 follow-ups. So we used what we had. And the cause pattern, you said? Yeah. Yeah, we understood as hypothesis is that children and adolescents that had to deal with multimorbidity, so more than one chronic disease during childhood, and adolescents had to deal with moments like the more use of medication, higher hospitalization. Some of them can have even some altered developmental because of the disease, dependent of the disease. So we understood that these could guide the adolescents to a lower development of social emotional skills. Yes, which Exactly. Yeah, the exposure is multimorbidity, and the outcome is the social emotional skills at 18. That was the pathway.
Okay, my name is Marley. Yeah, congratulations for the nice presentation. I have just one question for the first speaker. Yeah, for you. I was just wondering, did you look at the pre-pregnancy BMI and gestational weight gain trajectories? So just stratify by the pre-pregnancy BMI and look at your data.
Yes, we did this analysis and we saw that pre-pregnancy BMI, obesity and overweight is there's a connection as the association with the I think it's the fourth trajectory we saw, but don't bring to this presentation because we focus on social demographic factors. But there is association with the BMI, the pre-pregnancy BMI, and the trajectories. We saw that.
Yeah, did you look at interaction or something? Yeah.
What?
Interaction.
Yes.
Yeah, because when we are looking to one decreasing pattern or increasing, it depends on the pre-BMI, the pre-pregnancy BMI, probably. Yeah.
Yes. Here we did the trajectories based on the Z-score. Because of that, we saw this lower, I forgot the word in English. Trajectories, yes. So the interaction, thank you. The interaction is lower because of because we did the analysis according to the Z-score. Yes, but we can see association with the BMI in these trajectories.
Okay, thank you.
Thank you. Thank you for your question.
Diana again from Rio de Janeiro. First of all, I will try to help Giovanna, Marli. We use these Z-scores for cumulative gestational weight gain. So it considered BMI. So it was specific for BMI, pre-pregnancy BMI. So we have the Brazilian charts that were specific for BMI, and we classify women based on pre-pregnancy BMI. So we try to exclude this difference that we would see because of pre-pregnancy BMI. We try to, but we are exploring this. But thank you. And I would like to ask a question for Caroline, I think. All of you have very good presentations, and Caroline talked about malnutrition and different forms of malnutrition and double burden. And when we first think of the double burden of malnutrition, we could think primarily on different sides of it. I mean, underweight or low stature, and overweight or vitamin deficiencies and overweight. But what you observed was that the most common, or at least the higher problem, is that the mother is overweight and also the child. It was a result that you expected, or it surprised you in some way?
No, I think we were already expecting a higher prevalence of maternal overweight based on what we were observing in the field. But I was expecting also to find a combination of anemia with maternal overweight. We did not find that in the pair, but we did find that in the population level, because we have both profiles in the sample. Yeah, but we were expecting a higher prevalence of maternal overweight. Yes, thank you.
I'm over here on your left, Matt Gilman from US NIH. First of all, I'd like to thank all of you for really clear presentations, especially in a language that isn't your first, because I could never present in Portuguese. So thank you for presenting in English. And this is a question for all of you, since I think you're all students, and beginning your research careers, and these are very impressive presentations. What's been the most difficult or challenging part of getting from where you started to where you are now, being able to present a clear presentation?
I don't know if I understood right your question, but like what was the difficult part from the beginning when we just started and to now in regards to presenting? Is that it? Oh, the research. Wow. Yeah, I think it's exciting in the beginning because you are getting acquainted to a different subject. We have a lot of motivation, we have a lot of energy and curiosity. And I think in this path where you just keep studying the same thing every day and for years, I think the biggest challenge is keeping motivation and curiosity and always remember because we are studying the same thing, so we need to remember we do not know everything about the subject and we still have to keep our minds open to things we don't know. And so maybe for me, I think that's a little bit about it.
For me, that I'm in my PhD, I think the most beautiful part is being followed up by a very experienced researcher, very generous advisor. I think this is like crucial to your development as a researcher. And in my personal trajectory, it was very difficult because I spent the first 2 years of my PhD trying to work and study at the same time, and it's very difficult. I think the inequalities of in the research career in Brazil are very they keep people away from the university because you can't earn income that you can survive and live well. So I had to work in the first phase of my PhD. So I think this is something that compromises a lot of your engagement. Yeah.
So thank you for your question. I agree with the colleagues. I'm a nutritionist, so my PhD in public health nutrition, and now I work with physical activity. So this is a challenge for me because it's another field and another area of interest. But yes, it's a daily challenge, works with physical activity domains instead of nutrition and diet. It's much more easier. But I think that I'm excited with my research right now with the inequalities, because I think that it's a very important theme in Brazil, especially in our population. And I like a lot to work with the vulnerability groups and this Jeopardy index, because it's a new approach. So I think it's very interesting. So thank you.
Thank you for your question. I also agree with them. I think my biggest challenge is with my analysis because it's a new analysis to me and we have a lot of missings and we are trying to understand what to do with these missings, and I think it's the biggest challenge.
Well, after all that was already said, I just finished my under degree last year in nursing. So I finished last year and I started the master degree just. And I do believe that the most difficult part for me is that I didn't have I wasn't provided with a basic knowledge about epidemiology on nursing school. So we didn't talk a lot about it. And not epidemiology, not, and statistically, no. And not even close to statistically. So I do believe that it starts from the beginning. Like I finished an undergraduate course, and now I'm using like almost nothing that I learned there. It's like starting to learn all over again. And also academic space, it's very intimidating because everyone is so brilliant, everyone is so smart, it looks like everyone is a genius and you're not. So most of the times I feel like I shouldn't be here. At some point they will discover that I do not belong here and they'll kick me out. So it's like this self-esteem and ego work that we have to do with ourselves during the process. So I guess this is the most difficult part for me, to look at to people like you, sir, like you, for example, professor, and be like, that's okay, I can answer his question. And it's not easy. And as you said, especially in another language. But I think that is a feeling that everyone here in the end shares. That is this kind of what I'm doing here. They're gonna discover that I don't know enough. They're gonna kick me out. They're gonna send me home. And we are in the one of the best university of the country, so it's a lot of pressure. So I do think for me is this process of believe that I belong this place, that I belong to science. And I come from a poor neighborhood, and no one in my family ever belonged to the place like this. So it's hard to believe that I do. But I am working on it. I'm gonna be fine. I do believe so.
Thank you for the nice presentation. My question to Andrea. Andrea, did you expect the different social gaps between transport and leisure physical activity in the beginning of your study?
Thank you for your question. So we know for the literature that both leisure time and transport-related physical activity provide health benefits in physiological and mental outcomes, but their impacts, it's different. So leisure time is expected. Our results is according to the literature. So leisure time is higher among less vulnerable groups because it depends on safety and private facilities and living nearby green environments and access to leisure spaces. So this is much more available for those who had higher income and higher education. So it was expected these results. In contrast, we know that more vulnerable groups such as females, Black, brown, and indigenous with lower income and lower education face many times structural barriers such as violence and power lighting and lack of public transportation and unsafe infrastructures. So they had the lower levels of physical activity in leisure domain. According to transport-related physical activity, it's not expected, our results, because several studies have reported that transport-related physical activity tends to be more prevalent among lower income groups, because it's not only a matter of choice, but often a necessity driven. So the people undertaken out of necessity in unsafe and stressful environments. So it was expected that groups has the higher prevalence of transport-related physical activity. And in our case, our results showed that no clear differences between the lower vulnerability group and the higher vulnerability group. So we can concludes that maybe it is more influenced by other factors such as availability to public transportation or urban density, the proximity to workplaces and traffic jam that is affect different social groups in the similar ways in São Paulo. So this is our results. But no, transport-related physical activity is a surprise for us. Thank you for your question.
Thank you. Thank you very much. I was very interested to see your presentation about gestational weight gain. I've been involved with the National Guideline Committee in the United Kingdom in the last couple of years, so been very perplexed by what to recommend about gestational weight gain. In fact, in the UK, we don't routinely measure it. And one of the reasons is that what advice do you give to a woman when the ranges of gestational weight gain are so wide for a given pre-pregnancy BMI? So I don't know about your Brazilian ranges, which you recommend. So could you describe them a little bit to me and how you've come to the decisions about the gestational weight gain ranges for the Brazilian public? Thank you.
Thank you for your question. There's a new range. It was in 2022. There was a study to, I don't know how to say that in English, but to decide the recommendations for each pre-pregnancy BMI. So it was a study in our group, and then they used our database from Brazilian Maternal and Child Consortium, and they did the analysis and decide this range. So I don't know in my head right now to say the range, but I think it's 7 to 9 to obesity. That's it. And
that's much narrower than the American guideline. That's interesting because it's much narrower and therefore a bit more useful, I think, because it's I think it's a bit bigger, the range for high BMI. Carry on, sorry.
Oh, no, that's okay. And they decide this range based on the Brazilian Maternal and Child Consortium, the database, and they did the analysis and decided this range. I don't know the others range for overweight, atrophy, and
that was relation to which outcomes were being looked at? Was it relation to postpartum weight retention, diabetes, or SGA and LGA? Is that what was done? Yeah. Sorry, it's very interesting to me, but thank you.
I think I can help. I work with the group that create the recommendations. Here in Brazil, we used to use the IOM recommendations, but we observed that was very high for us, and we try to construct something based on our population, and we first developed the chart, but we are not satisfied with this because we need to recommend the ideal gestational weight gain. So we use a model to consider it low birth weight, small for gestational age, large, and preterm birth as well, but we also consider postpartum weight retention in these recommendations. And we would like to include more outcomes, but we didn't have information on them. So that was possible to do at the time. But we found out that our range were way more narrow than the IOM ones. It's kind of tricky because it's difficult to the woman to gain within the recommendations. So we are now see that we are classifying much more women with higher gestational weight gain during pregnancy, but we are still looking how we will shift our weight gain in public health, but the new charts are in the new recommendations for the Brazilian Ministry of Health, and we don't know much yet about the use of it, but it's something that we are trying to understand a bit more. I don't know if I answer your question. Yes, yes. I can send you the publication, both for the chart and then the recommendations, because we did it separately. But also, we discuss with, for the recommendations, we include the professionals that do prenatal care in Brazil, members of the societies, the Minister of Health. We discuss a lot to establish the acceptable range of risk that we use to recommend. So we use, I think, 10 to 20% of risk to establish the range. But that's it.
Thank you. I just one last question that I'm very interested to ask Nara. I love your work, Nara. It's a very sensitive topic, and I would like to make a comment and maybe to ask a question. So, as I said, I'm coming from New Zealand, and there I had the chance to work with a nationally representative data cross-sectional study, 13 to 19 years old, and for nationally representative prevalence for ideation, suicidal ideation in the past 12 months, 22%. And then we did an analysis in a convenience group of the Y-NEETs. Do you know what Y-NEETs is? It's an abbreviation for the youth that's not in education, employment, or training. And we compared with the mainstream, and it's 44%. It was 44%. So my whole point is, within the cohort that you worked with, do you think that is, I don't know if you have that information, that you could identify the Y-NEETs within the cohort and maybe run a disaggregated analysis to look at suicidal ideation or the things related like that? Yeah.
So we summarized the results to bring here, but we try to see this association with the adolescents that weren't in school and weren't working. And we had a greater association with those who aren't working, but not with the ones that aren't in school, because I think they're in 18s, so maybe some of them ended school, but it's very, very important. I think we found a very low prevalence, and I think it's way bigger. The problem is way bigger than we were capable to assess, mainly because of the question, I think, to kill myself. It's a question that is very strong in the present. So we can see this 12 months ideation or 30 days ideation. So I think it contributes to this lower prevalence, but thank you.
Thank you too. It was a pleasure to be part of this table. They're all brilliant, Professor. Why do you think I'm here? Because I know those Brazilians, they are amazing, great, and they're amazing. And anyway, we always want to collaborate with them. But thank you very much. Before, I need to correct a very big mistake that I made. I'm sorry, because I'm kind of half blind here these days. And I called my amazing colleague, Simone, and she's not Professora Simone, I'm sorry. It's Cecilia Cláudia Costa Ribeiro from the Federal University of Maranhão. Thank you very much. And Isabel.